Welcome to bill hearings for the House Health and Government Operations Committee. It is 1:09. As you know, we start on time in this committee. However, this is the time of session where we have less than, I think, 5 weeks now, a little less than 6 weeks. And I have to be available to put out a lot of fires. Last minute meeting requests, right? I have today 12 meetings between these hearings so that you see what my day is like and my members' day as well. 12 meetings with 12 different groups or people. So I ask for your grace, and we do respect your time. We do not take it for granted, okay? I'm your chairman, Jocelyn Peña-Melnick. I'm joined by my fabulous vice chair, Delegate Bonnie Callison, and today's lawyer for the committee. These bills have different lawyers. It's actually Aaron Hopwood to my right. I have a shadow today. You want to say your name?
Marsha Briley Savage. I'm with Emerge Maryland today.
So she's my shadow. So she's been running like crazy. I was telling her, eat something. You had 2 minutes to eat. So I think that's what you did. So I am going to go through some rules just to make her life easier. There's no eating in the gallery because it's tough for my team to clean it up. They don't have the time. You will see that we do drink here, but that's because we're sitting here for hours, okay? And we need to stay hydrated. I would like to start by being an example. Please put your phone on vibrate, all right? I don't want to hear music unless it's salsa or merengue, okay? And as a reminder, in this committee, I have decided not to time the sponsor of a bill, but please don't abuse it. Anyone else that is given testimony gets 2 minutes. And the timer will be displayed on the screen and you'll see it. When it goes off, I don't want to interrupt you. That's a key for you to just wrap it up quickly, okay? I don't want to be rude. And for our committee members, if you don't see some of them right now at their chairs, it's because they have bill hearings in other committees, but they'll be back. They watch the proceedings, and we also read everything, whether it's written or oral, in this committee. I am in a very humble way, this is a very thoughtful committee, like all the other committees in the House and the Senate as well. Members of the public are able to watch you live stream. So, those of you that are sitting there, when this goes on, we can see all of you. So whatever you're doing, we can see you. For my members this year, we have something new that is the closed captioning. It is amazing, and it came out of an experience we had in this committee. But it also picks up your conversations, and you may not want it out there. So be careful what you say. Today, the bill hearings will be in the following order, but I do reserve the right to change it because I have to figure out, is the sponsor here? Are the witnesses here? So again, I want you to give me some grace and do not take it personally if I change it, okay? For my members, voting this week will be tomorrow, Thursday at 1 p.m. instead of Friday. Next week, we will be voting on Wednesday and Friday. Hearings will be Mondays and Fridays next week, so please plan appropriately. For the subcommittees, we will be meeting much more frequently leading up to crossover, so this is all you do right now. There's nothing else that takes precedent, okay? Please monitor the MGA website for the committee meetings page and listen to floor announcement. Government operations, you're gonna meet after hearings. We have a subcommittee for government operations, okay? That being said, we're gonna start with Delegate Ivy, which is House Bill 765, Hospitals Medical Debt Collection, Sale of Patient Debt. If you could bring your panel while I make the next announcement, please. Then we're going to go on to House Bill 1324, Delegate Spiegel. Then House Bill 845, I have a fellow who's going to present that bill on my behalf. House Bill 926, House Bill 812, 871, 735, and then we're going to end with House Bill 962, okay? Because for that one, appropriations is going to join us. Some of the members of appropriations will join us for 962. So they're having a hearing right now on their budget for behavioral health. So I need to be flexible because we work very closely together with Chair Barnes and Chair Chetty as well. So Delegate Ivy, thank you for allowing me to make those announcements. How are you?
I'm doing so very well, and it's not just
How's that
because,
baby? Is he sleeping?
You know, someone asked me just before this hearing if he's sleeping well, and I said, yes, he is. But if he wakes up at 2 a.m. tomorrow morning, I'm going to have to blame someone for that. No, it really is a wonderful moment to see him growing into an actual person with personality, so on and so forth.
I'm glad you get to experience that.
Yes, my mother says that he's a nice dollop of karma because he's full of energy at all times, and he reminds her of someone that's sitting right here in this room today. Yes. So thank you so much for the time here today, Madam Chair, Madam Vice Chair, members of the committee, and specifically, Madam Chair, for your assistance on the local version of this bill. Which came through the Prince George's County delegation to this committee. We had a hearing on it, I believe it was 2 weeks ago now. This bill, House Bill 765, is correctly drafted into the appropriate stance, mirroring Senate Bill 1006 from last year, which passed both chambers and unfortunately on sine die just didn't make it all the way past the finish line. This legislation, as you've heard before, would allow for local governments, municipalities, to be able to purchase medical debt. And I think you all know better than most how crippling medical debt can be for so many people, not only in my county of Prince George's, but across the whole state and even across the country. So this legislation has been a labor of love. There will be people who testify or who have submitted letters of support, naming a few. University of Maryland School of Law, Mayor Brandon Scott sent a letter of support. Economic Action Maryland sent a letter of support. And I'm proud to hear that, quite frankly, because again, this bill has been vetted over the course of 2 years now. And I think we all know how important it is to give the opportunity for a local government to be able to purchase medical debt. It doesn't require it. It's not a mandate. But if there are extra funds available, which I know that they're scarce right now, maybe this won't be actually used for a few years. But when we get to those sunny days again, that we have this mechanism in place. I don't want to... I want to be mindful of the 2 minutes that you award everyone. But truly, I'm here in support of House Bill 765 and asking for a favorable report. And if you have any questions, I'm right here.
Thank you for your leadership and working with a committee on this. Are there any questions for the sponsor? Delegate Johnson.
Thank you, Madam Chair, and thank
welcome.
you for the bill.
Absolutely.
So I just want to make sure, I'm sorry, I didn't read through the whole bill. I was trying to scan through it. So it may be in there, but if, say, a municipality would purchase medical debt, so any liens or any liens that have been turned over to a collection agency, would that be wiped clean?
Yeah, that's the intent.
Okay.
And over the last 2 years, that's kind of been where we've gotten to with this legislation. But we do want to make sure that we protect our consumers, whether we're talking privacy or just them not having it impact their credit score anymore.
Okay.
So absolutely.
Great.
And if you don't mind, there is someone.
So you have another person on your, I don't know if she's part of your panel, Kathleen Hoke from Public Health Law Clinic. Is she part of your panel?
She wasn't a part of my sponsor panel, but
okay, go ahead.
I'm sure that she'll
Sorry.
speak to the bill. There was an individual who wrote in opposition to this bill, and she was saying that she agrees with the intent of it, but that she wished that it could go a little further. And I'm, of course, willing to work with the committee to make this bill be as powerful and also as concise as possible.
A follow-up, Madam Chair. Do you know in what way she wanted it to go further?
There are requirements that you have to meet in order for your debt to be able to be purchased and forgiven. She was looking to expand those.
All right, thank you. Thank you, Madam Chair.
And this is similar to the bill that we passed the year prior, correct? To
This is in
Baltimore
the
City, right?
exact stance.
Yeah, all right. Any other questions? And the reason is because the sponsor worked with the HSCRC
Yep.
before he brought it to the committee, and the committee appreciates it when people work their bills. Thank you so much.
Madam Chair, you suggested I speak to them, and they were incredibly helpful, and I appreciate their input and, of course, your guidance and your leadership here.
You're welcome. Seeing no other questions, thank you so much. We appreciate your leadership. Let's go on to Kathleen Hoke. Are you here? From the Public Health Law Clinic. Kathleen Hoke, not here. Let the record reflect it. I did call her, and she is not here. So this actually concludes the bill hearing on House Bill 765. Let's go to Delegate Spiegel. See, Delegate Spiegel, I got you early.
Thank you, Madam Chair.
House Bill 1324, and it is hospitals' medical debt collection, sale of patients' debt to nonprofit organizations. Delegate Spiegel. Do you have, I think you have, the Kathleen Hoke again signed up for your bill?
Madam
I don't know
Chair,
if you have anyone else.
Our understanding is that Kathleen Hoke had a medical emergency.
Okay, I'm sorry. I hope she's okay.
Thank you for that.
I hope she's okay. You can
Madam
get
Chair,
started.
thank you. Madam Chair, Madam Vice Chair, members of the committee, for the record, Delegate Ryan Spiegel, on behalf of House Bill 1324. The committee has, of course, heard a number of good bills designed to address the growing problem of medical debt. And I want to give a shout out to Delegate Ivey and his work in presenting the bill that came just before. I see the bill that I'm presenting to you today as sort of a backup plan or a supplement to the efforts that he has undertaken and the bill that was passed through both houses last year, but unfortunately didn't quite make it over the finish line. The difference with this bill is that we tried to keep it very narrow to avoid some of the potential regulatory and budgetary pitfalls that can come with more complicated bills. And there was some discussion about those issues in the version of the bill last year that you were discussing in the previous hearing. As you know, of course, under current law, Maryland hospitals are prohibited from transferring patient medical debt under any circumstances. And in follow-up to Delegate Ivey's important points, an estimated 12% of households in the state currently have medical debt that they and their family cannot afford. This issue disproportionately impacts low-income communities and minority households who are not only more likely to hold medical debt, but also face a higher likelihood of lawsuits and aggressive debt collection practices. Our bill would allow hospitals to sell medical debt only to nonprofit organizations for the sole purpose of canceling that debt. The bill is actually modeled after a successful program in Washington, D.C. last year, where nonprofit organizations facilitated the purchase and cancellation of $43 million in medical debt for 62,000 residents of the District of Columbia. So to streamline and focus our effort here, our bill does not include procedures for government entities to purchase medical debt. Instead, we're just focused on nonprofits being able to do it. Additionally, to avoid the concerns raised with similar bills, we do not require hospitals or nonprofits to verify income eligibility. And while that, in theory, would be a good thing to be able to do, it can become very complicated to do in reality. Instead, we think it's reasonable to assume that the overwhelming majority of bad debt held by a hospital and which a legitimate nonprofit would be willing to purchase in the first place is debt that a patient is unable to pay due to financial hardships. Also, the fiscal note states that there is little to no impact on the state's budget or on the uncompensated care system. I want to acknowledge some thoughtful proposed amendments from some of the witnesses who submitted written testimony, including the HSCRC, which we've been in communication with, and we are more than happy to work cooperatively with them on those amendments. But however we get there, if it's Delegate Ivey's bill, if it's this bill, if it's a combination of them, providing a pathway for medical debt cancellation is an important anti-poverty measure that can offer real relief to Maryland families struggling with unpaid medical bills, help hospitals clear bad debt off their books, and help unlock access to better economic opportunities. And so I respectfully urge a favorable report on HB 1324. Thank you, Madam Chair.
Thank you so much. Thank you for your work and your leadership. Are there any questions for the delegate? Vice Chair Collison.
Thank you, Madam Chair. Thank you. It's a brilliant idea, I think. The question I have is nonprofits, do they have the resources to be able to do this? I mean, my knowledge of nonprofits is not extensive, but it feels like they're often operating on very small margins just for their own operating expenses. Is this something we know can be done, I guess?
We have written testimony in the record, and I'm not sure if they're here to testify in person or virtually, Madam Vice Chair, but the nonprofit SEDEC DC has been very involved in this effort, particularly the effort that I mentioned earlier regarding the Washington, D.C. program. And they might be able to speak a little bit more to this issue. But let me point out that when you're selling bad debt on a secondary market, you're selling it for pennies. So one of the benefits here is that nonprofits, for a very small amount of money, could potentially purchase huge amounts of, at least what on paper is a significant amount of monetary debt. And that's how you leverage the ability of a nonprofit to get control of that debt and then immediately be able to forgive it.
And that's why I'm not an economist or an accountant. Thank you.
Thank you.
Thank you. Is your bill cross?
No.
Crossover? Okay. All right. Trying to see what are the differences we're trying to figure out between both, but thank you for being flexible.
Of course. Whatever will get us over the finish line. No pride of authorship here, Madam Chair. And if anybody wants to take any ideas that they think are halfway decent in my bill and put them in Delegate Ivey's bill, I'd be fine with that as well.
Well, thank you for being humble. Not everyone does that. Thank you so much. I don't see any other questions. Thank you for being with us. We really appreciate you.
Thank you, Madam Chair. Thank you, committee.
Most welcome. So I have Marceline White, and will you bring Jennifer Holloway? They're both on this bill. Marceline White? How about Jennifer Holloway? She is there? Okay. Good afternoon. You can get started.
Thank you. Good afternoon, Committee Chair Opinion Milnack. And
We can't hear you very well. Can you get closer or put the volume up?
Yes. Is this better?
Oh, that's so much. Oh, yes. Thank you.
Good afternoon, Committee Chair Pena Milnack and the Health and Government Operations Committee. Thank you for holding this hearing on this important topic. My name is Jennifer Holloway, and I'm a staff attorney leading the Medical Debt Project at ZEDEC DC. ZEDEC DC is an independent public interest law center headquartered at the University of the District of Columbia. Our mission is to safeguard the legal rights and financial health of DC residents with low incomes, dealing with the often devastating consequences of abusive debt collection practices and other consumer-related issues. As Delegate Spiegel mentioned, in 2023, ZEDEC DC recommended and catalyzed an effort by the DC government to use public dollars to effectuate a large-scale purchase and cancellation of medical debt. The district appropriated $900,000 in the fiscal year 2023 budget to award out as a grant to a qualified nonprofit with experience in buying and canceling medical debt at scale. Over the course of the next several months, the awarded nonprofit worked with a DC medical provider to identify medical debts for patients meeting the grant's criteria. Ultimately, the effort resulted in the purchase and cancellation of nearly $42 million in medical debt for 62,000 DC residents, despite only a portion of the proposed funding being used. This cancellation has provided immediate relief to DC residents. For example, one senior citizen had her debt from knee surgery canceled, and another shared that their $1,300 medical bill was canceled. Numerous others expressed their gratitude for this assistance. ZEDEC DC also helped catalyze faith-based private medical debt relief along the same model. These efforts led to the cancellation of nearly $8 million in medical debt for DC and Maryland residents. The bill under consideration today would allow Maryland's hospitals to coordinate purchase and cancellation of medical debt through a third-party nonprofit whose mission and purpose it is to purchase and cancel medical debt, with funding from either government or private philanthropy. Given how impactful this approach was in the district, we are supportive of Maryland extending this potential lifeline to Maryland residents. Maryland has been a leader in addressing medical debt, and we support this additional pathway to do so.
Thank you so much. Thank you for being here and for lending your voice. It really matters. Are there any questions for this witness? Yes, Delegate Johnson.
Thank you, Madam Chair, and
My
thank you,
pleasure.
Jennifer, for coming to speak with us today. Was all of the debt that you paid off, was it all government dollars, or was there any other funding involved?
We did have some private funding as well. A church-based group and a temple in DC fundraised privately to purchase and cancel medical debt through the same nonprofit.
Do you know what percentage the private funds were?
There were private funds that were used to purchase about $8 million in medical debt and cancel it, and the public funds were used to purchase about $42 million in medical debt.
All right, thank you. Thank you, Madam Chair.
Really impressive. Very impressive. Thank you. Any other questions? Seeing none, the committee wants to thank you for being with us today, okay?
Thank you. For
And
having
thank
me.
you, Delegate. Oh, you're welcome. Thank you, Delegate, for your leadership. This actually, Marceline White here? All right. This actually concludes the bill hearing on House Bill 1324. Next, we have House Bill 845. And if you're wondering why I'm calling it now, it's because there's a bus that's taking some of the advocates back to Baltimore City at a certain time, so I need to call it now. Not because the sponsor knows the chair, okay? Thought I would like clarify there. So this is House Bill 845, and it is Delegate Peña-Melnick. The bill is going to be presented by Dr. Halia Melnick. It is Public Health Overdose and Infectious Disease Prevention Services Program. We're going to have if I may have Dr. Halia Melnick come to the table, followed by Christine Ogbu, Molly Greenberg, Samantha Kerr, Rachel Young. How about Christine? And will you please bring Tony Smith, who's virtually? And if you can have a seat. And we are ready when you're ready. And remember that the sponsor is not time and the others have 2 minutes. And welcome to HGO.
Thank you, Madam Chair, Vice Chair, and members of the committee. I'm honored to speak to you today in support of House Bill 845, Public Health Overdose and Infectious Disease Prevention Services Program. I'm sure we all share a concern about the effects of the opioid epidemic on our communities and want to reduce its impact, especially reducing deaths from overdose. What this bill does is authorize local communities to set up an overdose prevention center, or OPC. These centers provide a safe place where people who use drugs can be monitored and treated for an overdose event. OPCs also provide on-site services and referrals to address the broader health and social needs of people who use drugs. House Bill 845 would allow up to 6 OPCs to be piloted in non-residential areas with high drug use. There are 3 problems this bill is trying to address. First, Marylanders are dying from drug overdoses. Second, responding to these incidents places a significant burden on emergency response services. And third, treating overdoses is costly to U.S. consumers and taxpayers. Of the estimated $11 billion in healthcare costs associated with overdose treatment in 1 year, more than half is said to be borne by Medicare and Medicaid. Let's be honest, we can't wave a magic wand and cure the afflictions caused by drug-related overdoses. I wish we could. But we can do things to lessen the harm to people who use drugs and the community at large. OPCs provide harm reduction care. They do not provide drugs, just a safe place, and we've seen them at work. Since opening in 2021, the trained staff at New York City's OPCs have reversed over 1,700 overdoses without one death. While answering a need for urgent life-saving interventions, OPCs also reduce the need for ambulance calls, ER visits, and hospitalizations. They reduce the need for treatment of HIV, Hep C, and skin infections, and they reduce the need for police narcotics enforcement activities. In some, OPCs have multiple benefits. They improve health outcomes. They're cost-effective. House Bill 845 fills a critical gap in our response to the opioid epidemic. An estimated 40 to 60% of individuals who undergo treatment will resume drug use at some point. OPCs provide a non-judgmental environment in which people can manage a complex, often chronic disorder. Practically speaking, OPCs provide bathrooms, showers, laundry facilities, and the means to properly dispose of used needles so they don't litter neighborhood parks and streets. From a public health perspective, they integrate strategies, prevention, risk reduction, and health promotion into one package. In OPC space, people can navigate from chaotic drug use patterns to more self-directed and purpose-filled lives. Drug overdoses recently accounted for over 100,000 deaths in the U.S. annually. Roughly 1,500 of the people who died last year were Marylanders, and 40% of those were Baltimore City residents. These deaths are preventable, just like motor vehicle accidents. Think about our approach to reducing highway deaths. We improved road design with better lighting and guardrails, and required cars to be made safer with seat belts and airbags. Yet, while the number of overdose deaths exceeds that of car accidents, there is societal reluctance to invest in preventing those deaths. Why is that? OPCs would decrease the burden on emergency response systems, police, fire, and ambulance. OPCs would save hospitals and taxpayers money. OPCs would improve the quality of life in neighborhoods. And OPCs would help connect people to life-saving and potentially life-changing services. When you think about it, OPCs make sense. I urge you to vote in favor of House Bill 845. It's the right thing to do. Thank you.
Excellent. Great testimony. Next, please.
Thanks.
Thank you, Madam Chair.
Good afternoon, Chair Pena Melnick and members of the committee. My name is Dr. Christine Obwe, and I serve as the Assistant Commissioner for the Bureau of Ryan White and Community Risk Reduction Services at the Baltimore City Health Department. I'm here on behalf of the Baltimore City Administration to support House Bill 845. Overdose deaths are preventable. A proven and effective way to prevent them is to legalize overdose prevention centers, or OPCs. OPCs provide safe spaces for people experiencing addiction to use in the presence of staff who are trained to prevent a fatal overdose, rather than in unsafe locations alone or in public spaces. They also ensure people's basic needs are met through the provision of wraparound services that include mental health resources and linkage to treatment. In short, OPCs save lives and support the health and dignity of the people they serve. Since launching in November of 2021, On Point, an OPC in New York City has reversed more than 1,700 overdoses. That's 1,700 times people did not lose loved ones. Additionally, OPCs are not associated with increases in crime. Over 100 scientific peer-reviewed studies show the positive impacts of OPCs. These include increased access to and engagement in treatment, a reduction in HIV and hepatitis C infections, a reduction in the amount and frequency clients use drugs, cost savings for medical systems and local government through a reduction in emergency medical service calls, and a reduction in syringe litter. The evidence shows OPCs are effective. I hope you vote favorably on this bill so we can add OPCs to the toolkit of resources to address overdose in Maryland and support people on their road to recovery when they are ready. Thank you.
Thank you, and thank you for your work. Next, please.
Chairperson Pena Melnick, members of the committee, good afternoon. My name is Rochelle Young, and I'm submitting my testimony to you today because I know drug users. I love drug users, and I support overdose prevention sites because I don't want my friends to die, and I don't want to die. I volunteer with a group of harm reduction workers who test drugs at music events. We use reagents, which are chemicals that change color when in contact with certain drugs. We have also partnered with a university to borrow a mass spectrometer to measure down to the percentage the content of the drug. People line up outside our tent at music festivals to test with us because people want to know what they're ingesting and to do so safely. At one festival I worked at, we found fentanyl. The person who brought us the drug for testing did not intend to use fentanyl. She thought she had bought something else. Along with medical personnel, we were able to find the person who had sold it to her, who also did not know it contained fentanyl. He had intended to use it as well. We were able to save multiple lives that night because we could safely test the drugs and provide immediate access to life-saving interventions, such as naloxone, in the event of an overdose. And that's why overdose prevention centers are essential. A safe, regulated, and supervised space to use drugs should not be a privilege only available to people who can afford a music festival ticket. It should be something that everyone has access to. Overdose prevention sites would provide that access. Nobody deserves to die from drug use. For these reasons, I urge you to vote yes on HB 845.
And I want to take a minute just to say thank you for sharing your personal story, because it
Thank you,
does matter,
Chairperson.
okay? And the committee appreciates it, and
Thank
for
you
the
so
work you
much.
do. Next, please.
Good afternoon, Chair Pena-Melnick, Vice Chair Coulson, and members of the committee. My name is Molly Greenberg, and I'm a nurse and harm reduction manager at Healthcare for the Homeless, here in strong support of HB 845. I've been working as a nurse supporting patients who are not ready or not able to stop using drugs for 11 years. I respond to overdoses, provide sterile supplies, prescribe medications, tend to wounds, advocate for care coordination, and sit with patients in moments of overwhelming gratitude and grief. Every day I see how stigma and criminalization pushes people to use in isolation, making them more prone to overdose. I could tell you the stories of these patients who die alone, but today I will tell you one about survival. This is a newer patient who arrived to our clinic in respiratory distress, and a code was called. I found her seizing and then unresponsive in our waiting room. Her friend said she had used earlier that day. Her oxygen levels had plummeted, and I administered naloxone while my coworkers called EMS. Within minutes, she returned to consciousness and ultimately declined transport to the emergency department, stating that she did not trust the hospital. Afterwards, I felt gratitude that she was in the building and sorrow that her overdose might have been prevented if she had had a safe place to use. An OPS would have given her unlimited time to recover from a near-death experience with the love and dignity she deserves. OPSs do more than prevent overdose. They provide access to basic human needs and are sanctuaries of compassion and community. Places where cycles of shame and stigma die, leaving space for connection and healing. Data showing that OPSs lower mortality, reduce EMS calls, and decrease the spread of infectious disease has now long been embraced by esteemed medical and public health associations. Investing in harm reduction interventions like OPS sends a message to my patients that their lives matter. Every day I bear witness to people's pain, attempt to alleviate it just a bit, and feel complicit in perpetuating it, because in this system, what we do falls short of what people need and deserve. While we sit here debating the merits of OPS, my patients, your constituents, are dying. These deaths are preventable, and every single one is a policy failure. You have a solution in front of you. Thank you so much for your time, and please pass HB 845.
And thank you for what you do. I really appreciate it, okay? Next, please.
Oh, Shiza. Hi, my name's Samantha Kerr. I am an alcoholic, and I'm also a member of Bridges Coalition, which is the Coalition for Overdose Prevention Centers in Maryland. I also work at Baltimore Harm Reduction Coalition, which is a syringe service program. We also do policy advocacy. I never really know what to say whenever we do this because I've been doing this for like 7 to 8 years, and we say the same statistics over and over again. And sometimes we have new ones because, you know, we learn things like On Point is saving lives. But I have a really hard time coming and sitting in the seat, and as a harm reduction expert, right, coming forward with other harm reduction experts, with people that use drugs, people that use all kinds of drugs, coming to the space and asking for y'all to hear us and to see the stuff that we're bringing forward and believe in us and believe in all of the facts and all of the data that we're bringing to you to make these legal. I am sitting here as opposed to William Miller Sr. I'm sitting here as opposed to so many other people that, since we have sat here and done this, have come to this space, who have advocated for these life-saving treatments, who have then used and died alone in other spaces, and don't get to come here and ask for this. They don't get to come here and do this. This is an experience that every constituent should have, especially people that use drugs, to come here and to advocate for themselves. And he doesn't get to do that anymore because we did not have one, and he used alone and he died. There are so many other people like that. And so you're gonna hear from more experts, and they're gonna give you the numbers and the figures, but I also just want to say that these will save lives. Please vote favorable. Thanks.
And thank you. Thank you for your work, for your leadership, okay? And I know it may seem frustrating, right? I have been putting this bill now for more years than I want to say, because it is the right thing to do. Unfortunately, it's not everyone feels that way. And we're trying to educate people, right? And we'll get to some questions later, but I don't want you to leave here thinking that, you know, that we don't hear you, because we do care, okay? And
Thank you.
You're welcome. Delegate Kaiser.
Thank you,
I'm gonna
Madam.
open it up for questions. I think everyone went.
Tony, you have Tony.
Oh, I'm sorry, I have someone. Tony, 1 minute. Tony, you have a lot of advocates here. They were like, Tony, Tony. So, how are you, Tony?
I'm doing well, thank you.
Good to hear you and good to see you. Go ahead.
Okay. Good afternoon, Chair, thank you, and committee members. My name is Tony Smith, and I'm the New York State Director at the Drug Policy Alliance. In my role, I work very closely with On Point NYC, which, as you know, operates New York's 2 overdose prevention sites. In my role, I've participated in tours of the sites for hundreds of stakeholders. And in these tours, I have observed that there is a common disconnect between the public discourse that often drives policy and the private ways families are supporting their loved ones. It is this disconnect that visitors to New York's overdose prevention sites are confronted with when they visit On Point. What they see is a community center that feels much like how they have practiced care for their own loved ones in their own lives. Overdose prevention sites are community-based health centers that include a designated space to ensure trained personnel are in proximity to see the earliest signs of overdose and respond to prevent death. This simple design of creating a designated space acknowledges that although we are in an overdose crisis, with the knowledge of where an overdose will occur and being trained to respond, we can prevent overdoses from becoming a crisis. At New York sites, staff have prevented overdoses from becoming a crisis over 180,000 times. Overdose prevention sites also provide an appropriate setting for people who are in active drug use. New York sites largely serve people who lack housing, bathrooms, showers, and other private space. Over 80% of the participants at On Point report that without access to the site, they would have used in a public setting. Overdose prevention sites are an effective response to public drug use and related litter, and a necessary response to the overdose crisis, which is still escalating for many of our communities. And we support passage of HB 845 and hope you will too.
And thank you for your work, and thank you for making time to be here. So now we're really opening it up for questions. Delegate Kaiser.
Thank you, Madam Chair.
My pleasure.
I wanted to ask a question. I am a co-sponsor of this bill, so I support it. I just wanted to give you all an opportunity to respond to a critique I hear that I'm sure you've heard in the past, that creating centers like these blesses the use and makes the opportunities worse. And so I just want to, and I'm not using the right words right now, so I apologize, but I just wanted someone to address that argument that's often stated.
Cool.
To answer that question.
It looks like it's,
Okay.
I'm gonna do it, I think.
Sure.
So what I heard you say was something that I've heard people say a lot, which is if an overdose prevention center happens, it's going to enable drug use, is what I'm assuming you're talking about. And there are multiple ways to answer this question. One of those ways is that drug use is happening anyway in a lot of spaces, right? We just heard from Tony and we've heard from others, and I know that people have seen that there's drug use that's happening in public spaces. There is drug use happening in people's houses. There's drug use happening on a lot of different places. The opening of a place for people to go to get wraparound services and also be seen, and be monitored is not going to doesn't enable the use, it makes the use safer for the people. And when you make the use safer for the people, you give them the opportunity to access the wraparound services that are there, right? If it's someone that's homeless and they're using within the center, they have a space in which they can get a cup of coffee, they might be able to do their laundry, maybe shower, there are other things. And if they're homeless, they might be able to talk to someone who can give them the opportunity to start a housing process, right? And once people's needs are met in those ways, then they get to make the decision of I actually don't particularly want to keep using in this way. Is there anything I can do about that? And when they are continuing to go to that space and they want to have that conversation, that's a part of the wraparound services. There are people that are there that can speak to them about that. So drug use is happening, and it's happening everywhere. And the last thing that I'll say is that there was a study done, I think, by Susan Sherman, which we can get to people, that it takes 7 times of going into treatment for it to stick for a certain amount of time, right? So we're in a space right now where we have people that are actively using, and they're actively using in all of these spaces, and we have sober people. And so what is the middle ground, right? What is the middle ground? I've named that I'm an alcoholic. I spend a lot of time with alcoholics and people who use drugs or used to use drugs. And the amount of people that have been in and out of treatment multiple times is large. And so what do those people do when they're not in treatment? If they're using, if they have left treatment or if they left abstinence-based recovery, they're using drugs. Where are they using drugs? The stigma that is being attached to drug use, they're using alone. They're using alone. They might be using inside alone, but they might be outside alone. It's a risk for overdose for people to leave recovery in that way and then use. And so, again, people are already using drugs, and we also need a space for that middle ground of people that are using, that may or may not want to use, but they are using, and they need the compassion and the love and the space to be able to go be heard, be seen, and make sure that they can live another day to make a decision on what it is that they want or need to do.
Delegate Martinez, followed by Delegate Taveras.
Thank you, Madam Chair. And before I get to my question, I just want to thank you all for the work that you all are doing. When I was in high school in the IB program, my math internal assessment was about the UK and Margaret Thatcher's needle exchange program and how the correlation between clean needles help reduce the rate of HIV. Could we talk a little bit more about the infectious disease component of this and how, places like Prince George's County that I represent, Baltimore City, a large part of the spread of HIV is because of this, exchange and the stigma around needles. Could you guys talk some more about just navigating that for us?
I will come to you, Maggie. I just wanted to share a statistic that we often share when talking about the effectiveness of syringe services, and these services will be available, or these services are available in OPCs. But in Baltimore, when our syringe services program was established, people who inject drugs were accounted for 76% of the new cases for HIV in 1994, the year that it was established. And our most recent data from 2022 shows that that same group, people who inject drugs, only account for less than 10% of the new HIV cases. So I just wanted to put that out there to show the effectiveness that we've seen in Baltimore City, and folks who engage with OPCs will have access to those services. Is there anything you want to add, Maggie?
I mean, I think you said pretty much all of it. I will just add really quick that, in an OPC setting, you have those resources, like we mentioned, you have the resources, not just the preventative resources, like access to clean needles and all of that, but also testing, the ability to sit with somebody and talk about, treatment, about talking about how, if you are HIV positive, maybe for some reason that viral load, how to be, untransmittable, zero viral load, untransmittable. So there's room for those kinds of conversations that might not, that happen in health care settings, but is happening in a more organic space with trained healthcare providers available. So that's a really big plus. And I think, everybody here said it, years and years ago, there was so much pushback against needle exchange, that was such an outrageous idea. And now we know it works, right? We know it works. We know this works too. There's just a lot of hesitancy to take that risk and try it.
No, I agree with it working. We no longer can legislate in silos, and so this is clearly a consortium of care, right? You come in for one thing, but you ultimately are exposed to different things with experts that can help you navigate that, and I think all of us deserve healthcare settings where we can get the optimal care. So thank you, Madam Chair.
Delegate Taveras, followed by Delegate Bagno.
Thank you. This is a difficult bill for me just because I too sit on both sides of the equation. I don't know if you were here last year. It was tough. And this year I have several bills that are aligned with your efforts. My question is, I think the big hurdle, thank you. Oh, I could hear people. Thank you. Oh yeah, this is so much better. So, there are people, the big issue in our district is that there's a lot of people that are going to be hanging outside, right? And it brings a bad element to the neighborhood, right? That's the argument that we hear. I mean, in New York, us being from New York, it doesn't matter what time of night, there's gonna be somebody in the corner. Nobody cares. That's how New York rolls. But here, it's not the same. Things shut down pretty much after 8, 9 o'clock. At midnight, maybe there's like a tumbleweed. So how do you respond to those concerns?
Who's doing it?
One person.
All right. I need a second. After doing it for a while, I have a lot of different answers for things. For this one, specifically, whenever we're talking about people hanging out, I think that people have an imagery of methadone clinics and which is a whole other thing. People shouldn't have to stand outside in line for an extended period of time. And so there are methadone clinics in Baltimore City and other places where people are standing in line outside, and that is something that people see and don't care for. And a comparison that we get a lot whenever we're talking about overdose prevention centers, they're like, oh, well, it's going to be a line, there are going to be people, it's going to be a whole thing. The point of the overdose prevention center is for the people to be inside. So the people would be inside. That is the entire point. It's for them to be able to come inside to do what they need to do, to hang out in there. It's a space that has room for people to chill out, we've talked about getting coffee and getting all these services. That does have a space in which people can just kind of exist. And so, when I've gone to On Point, what I've seen going to the different sites is like normal traffic of people just walking up and down the street. I haven't seen people congregating outside of these spaces. I see people inside. So that is my response to that for right now. Also, I want to name I am still deeply sorry and sending love.
And just as a follow-up, the way the bill is drafted, it will be in what type of residential setting?
Non-residential.
Yeah, non-residential.
Okay, thank you. Delegate Bagno.
Thank you, Madam Chair, and thank you all for being here. I don't usually say a lot at this bill hearing, and every year it's tough because I do hear those concerns raised. And I hear, things like, well, if people are choosing to take drugs, why should we care? And yet we don't have that discussion in any other area. We don't say you choose to drive, so why should we make cars safer and highways safer? We don't say that you choose to eat, so why should we make food safer? And yearly, I have parents and constituents who come into my office because they've lost their children. And so I have to remind folks that the bad element are someone's child. So, so while we have you here, can you talk about the value and the impact of that shared experience in an environment that doesn't make those judgments, that doesn't stigmatize that safer aspect of drug use, and what that does for people who are going to those sites and utilizing those services?
I think we should throw it to Tony. Tony, can you speak to that?
Sure. Thank you so much. The community piece of overdose prevention centers is critical. I love the saying that I'm looking at those of you on the panel, a saying that all of us often say often, which is the opposite of addiction is not sobriety, it's connection. And when we are often in the conversations around people struggling with drug use is the desire for people to be stable and well. And becoming stable and well is not just a matter of talking about someone's patterns of drug use. It is talking about what their entire life is looking like, what opportunities are available to them to connect with other people, to connect with community, to have access to services. And for people who are largely using overdose prevention centers, often, largely, they're people who have been disengaged from family, community, services, pushed away from different kinds of healthcare, housing, jobs, other forms of income, like you name it, really being pushed away from being able to form bonds and community in all parts of society. And so the focus on the use is really ignores what it means to be human and what we require to thrive. And what we require is love, support, community in order for us to want to make different choices, be able to make different choices, and be more stable so that we are better positioned to even think about other things we may want for our lives. And so by inviting people into overdose prevention centers, you're acknowledging that in order to support people with all of the other choices you want to make differently, we need to address the thing that is most pressing, which is the need to self-medicate pain. And without acknowledging that, it really hinders the ability to talk about anything else.
Delegate Bandari.
Thank you, Madam Chair, and thank you for a wonderful testimony defining why this bill has a proactive and evidence-based and that prevents overdose and connect the individual with critical health services. And thank you, wonderful Chair, for her leadership as well. And this is a wonderful bill, there is no doubt. So as we educate the public who do not understand the intent of the bill, how do we ensure, you guys are expert, you have been doing this for years, how do we ensure that public understand this bill is about harm reduction and saving lives? And what step can we take to engage communities, address misconceptions, there is a lot of misconceptions, and ensure that these programs are successfully integrated into the areas they service?
Do you want me to?
Can I?
Okay.
I'm going to do it if we're going to do this.
right
Okay,
ahead.
cool.
Yes.
Do you want to do it?
Okay.
Okay, cool. I'm going to do it. We got to do it quick because I'm going to forget the question. Okay, so that's a great question because obviously your constituents are the people that vote for you. You're the ones that make the decisions. It's a great question. I will start by saying that every person that I know, obviously I'm an alcoholic in those spaces, but every person that I know is affected by drug use or alcoholism in some capacity. And so there is trauma that is connected to that with a lot of different people, and a lot of different people have a lot of different views, right? There's a lot going on. And there's a lot of history involved with that. And so it's a delicate issue to talk about, obviously, right? And so one of the things that we do, we as in BHRC, Bridges, all the members of Bridges, there are like 30 members of Bridges, and just so many other people in this space. What we do education-wise is we meet people where they're at, and we meet them where they're at and talk to them and move them from that spot to any spot if we can, right? I'm here talking to y'all about this, and I'm meeting you where you're at, right? I'm not yelling at you about different things. It's like, it really is about hearing the things that people disagree with, and then going to them, meeting with them, and showing the evidence, showing the humanity, and having those conversations. And so one of the things that Bridges Coalition has been doing for the last couple of years is setting up overdose prevention site demonstrations, and we invite people to come see those spaces, right? We want you to come see it, we want you to come see what it looks like, so that they can understand that it looks different than you think it does. It always looks different than you think it does. But education is one of the biggest things that we spend our time doing through social media, through workshops, through going into communities, because a lot of the spaces, the syringe service programs and other people, we go into community and we tell them about these things. There are people in Penn North that are like, where is it? We tell them about this and they're like, where is that? And I'm like, that is a great question. So education, and it is difficult to walk through that education through the stigma that exists, but there's a force of people that is continuously dedicated to walking, meeting people where they're at, and continuing to show them harm reduction as a part of the solution and not part of the problem.
Thank you.
Thank you. Delegate Hill.
Thank you, Madam Chair, and thank you, panelists, for your work. Madam Chair, this question is for you, but you can always pass it off. You've introduced this bill a number of years, and it reminds me of how long it took to get clean injection needle exchange programs and how everyone was concerned about that, and it turned out to be really quite a blessing in terms of healthcare and decreasing infection rate and that kind of stuff. So I guess the question is this. The fiscal note is zero. What have we lost by not having done this 2, 3, 4 years ago? And what do we lose if we don't do this year?
100 people that died last year, and 2,100 that died the year before. We're losing lives. We're losing lives. And the reason is because most people that OD by themselves, they're in their apartment by themselves, they're in a dark alley by themselves, they're in a bathroom by themselves. They don't have a loved one to administer naloxone, right? This will give people a safe space to come and use their drugs. There is a lot of misconception, and it's just some people feel that, oh, you passed that bill and you're giving drugs to young kids. This is not about that. Let's stick with the facts, with the evidence that it actually works. It is 100% evidence-based. There are over 120 overdose prevention sites in the world, 11 countries, including Australia, including Denmark, France, Germany, Luxembourg, the Netherlands, Norway, Spain, 2 locations in New York. It works, and it keeps people alive. The drugs are not being given. They're bringing them. Let me say that again for the whole world to listen. They are bringing the drugs. They're not giving it to them. It provides a safe space until the person decides that they're ready to seek help. I went to Point in New York, and I went to it. I visited. You go in, it is calm. They greet you. You go into the room where you're using the drugs, and they're professionals that observe what the reaction is. You want to go upstairs and take a nap? They're cots. You want to take a shower? You want acupuncture? It is holistic. The fact is that our kids are dying. And it is not just Baltimore City. They're all over the 24 jurisdictions in Maryland. But I want people to stop using this bill and saying you pass it, you're going to give kids drugs. This has nothing to do with giving kids drugs. People are buying it, they're getting it, they're using it. It's about saving lives.
And is that
plain and simple.
Is that why the witnesses are all favorable, and these are professionals who are medical professionals, addiction professionals, professionals who work in this field and know the day-to-day dealings, that what addiction means, and is that why they're all in favor of this bill?
Absolutely. It is why they're all in favor, because it is evidence-based 100%. You know, and I don't know, I am a person with a lot of faith, and I have family members and kids. And for someone to say no when it has not hit your door, this can happen to anyone that has a loved one, but it keeps them alive until they're ready to seek help. Anyone else? Thank you. Thank you so much for your work and for your testimony. We really appreciate you. We value the experiences that you have shared with us, okay? You are loved and cared for in here. And if it takes 100 times, we will keep bringing it, because it's about education. It's about education. It is about the facts and not distorting it. Thank you.
Thank you.
Thank you, Madam Chair.
Let's go to Ro Johnson, Jesse Dunleavy, Tiffany Scott, Ruth Carlock, and Kola Anderson. Will you be so kind and come up, please? Again, Ro Johnson, Jesse Dunleavy, Tiffany Scott, Ruth Carlock, Kola Anderson, Morgan Carroll, are you here? And can you bring the person who is virtual? The two people virtual. Is there some, virtually, excuse me, is there someone that didn't get called that would testify in this bill? Can you please come up if you signed up and I didn't call your name, because this is the last panel. All right, good afternoon, and thank you everyone that's waiting. I know that we have other bills and we're gonna get to them. Thank you for being patient. Will you be so kind and get started?
Me?
Yes, please.
Okay. Dear Chair Pena Melnick and members of the Health and Government Operations Committee, my name is Cola Anderson, and I'm a community organizer and leader of the Bridges Coalition for Overdose Prevention Sites. Bridges advocates for overdose prevention sites by advancing harm reduction strategies to improve health and justice in and around Baltimore, Maryland. I am also a person who uses drugs. Overdose prevention sites give people who use drugs, especially those who are homeless, access to places where they can use drugs safely, without judgment, and with newfound community. These sites save lives immediately, period. We know this because we see them doing so all over the world. Bridges also knows this because we've spent the past 3 years working closely with OnPoint NYC, an overdose prevention site in New York. Between 2022 and 2024, we brought city and state council members, public health officials, Bridges members, and others to New York to see OnPoint, including the mayor, who has named overdose prevention sites in his priority list. Everyone left differently than how they entered. Regardless of any additional questions about what they may have seen, they felt the magic that is overdose prevention sites as harm reduction. The work we do together in Bridges to promote authorizing OPS is so impactful. All that we do is built on the foundation of harm reduction, safety, and doing the work to honor and remember those we lost to overdoses. For example, Bridges has done non-operational overdose prevention site pop-ups for years now. These spaces have been used in the way galleries are to show people how an OPS can be set up and to learn about the additional benefits it provides to the person using drugs. Many who came to these pop-ups were in awe about how simple, clean, and relaxed these environments could be. It made it much easier to picture how it could work in reality. This is an emergency and we urge you to act now. We ask for a favorable report for House Bill 845. Thank you.
Sorry, I appreciate it. Next, please.
Hi, thank you, Chair Pena-Melnick and committee members for letting me speak. My name's Jessie Dunleavy. I'm a lifelong Marylander. And since my son's fatal overdose in 2017, I've devoted myself to drug policy research. My son was shamed and humiliated. Healthcare was out of the question. Incarcerated at one point for a relapse, he was sexually abused, he was hungry, and he was afraid. Sweet-natured with disabilities, he was no match for the brutality of the systems available to him, including treatment programs. Kindness was coddling, enabling, a tragic mindset that cost him his life, and it gave us the world record in overdose fatalities and numbers of inmates. But since then, we've learned we can't conflate addiction and moral deficiency. We've learned that people struggling with addiction are almost always victims. Punitive measures add disadvantage on top of disadvantage. So now we do support some life-saving initiatives. Naloxone's a good example, drug test strips. And these are the reasons that our overdoses have started to decline. But this piecemeal approach is not enough. We need all the proven strategies working in concert, and crucial among them are overdose prevention sites. They save lives, they curtail the spread of disease, and by affording dignity over shaming, they maximize connections to voluntary treatment, which increases the likelihood of recovery. Why the reluctance to these proven life-saving and money-saving initiatives? It's bias, unfounded but pervasive. There's fear of appearing to condone drug use. The way I see it, we made drugs illegal, which in turn made them deadly. Then we punished its victims and denied them health care, despite overwhelming proof that safe use keeps people alive. And one thing I wonder is how it is that we've always been comfortable with prisons and jails where dehumanization is the norm and abuse is routine, but uncomfortable with evidence-based health care that has proven to reduce deaths and promote recovery. Why? I hope you pass this bill. Thank you.
The loss of your son, okay?
Hi, thank you so much. My name is Morgan, and I actually didn't make the Senate hearing, so I'm going to speak to my senator as well, which is President Bill Ferguson. I would really like for him to hear this. So when I was just 6 years old, I was playing Marco Polo in a hotel pool with my sister. And before I knew it, I was in over my head. I had drifted into the deep end, and I was not a strong swimmer. I was in crisis, and I cried out for help. Without a second thought, my dad jumped into the pool, fully clothed, flip phone in pocket, so you know it was gonna break, and got me right out. He saved me. And if he were here today, he would be able to tell you all the other times he answered the call when I was in need. Stitches in my lip, staples in my knee, I was a heck of a kid, and my dad was there every single time. But he isn't here today, because 2 years ago, my dad died from an opioid overdose. He received an opioid prescription back in the early 2000s after a traumatic fall, and it wasn't long before my dad was in over his head. He too had drifted into the deep end. And he cried out for help, but they were not met with compassionate action as mine had been. Rather, his struggles were criminalized, and he was forced into the shadows, unsure of how to get back out. Losing your dad before you even turn 30 is devastating. This year, I married the love of my life, and my dad won't be there to walk me down the aisle. But this epidemic is so much bigger than just me. Every facet of our communities are being impacted. Librarians are calling for help when they find a person using drugs slumped down between the stacks. Small business owners are losing customers because their streets are littered with needles and their bathrooms are used as refuge. At her job, my baby sister, while grieving the traumatic loss of our father, was forced to check on people using drugs in the Starbucks bathroom to make sure they too had not overdosed. Our emergency rooms, our police forces, and our everyday pedestrians are overburdened and underprepared to handle this substance use care. These Marylanders are not equipped to handle this, and our harm reduction workers are. They have been doing this work for years, and all they are asking for with this bill is the opportunity to be with their clients during the moment of use so they can reverse an overdose and save a life. They have been around for decades. We know the impacts they have, not just on people who use drugs and their loved ones, but on the entire community. They decrease public drug use, they decrease needle litter, and in some cases, they even decrease criminal activity. They do not encourage drug use, and they do not operate as open-air drug markets. Most importantly, overdose prevention sites save lives, and that is the most important thing. My dad's death was wholly preventable, and I wish he had access to the services I am fighting for here today. People who use drugs want to be productive in our communities, and many want to overcome their addiction, and I know my dad did. But to do that, they need to stay alive. As a state, it is our duty to keep our residents safe and our communities whole. This is what Maryland does. When people cry out for help, we must heed the call. Thank you, and I appreciate the time.
Thank you for sharing your story. He sounds like an amazing human being, and I know he's very proud of you today. Next, please.
Good afternoon, Madam Chair, Vice Chair, and our respected committee members. My name is Tiffany Scott, and I'm a parent, family member, and community member of Baltimore City. I asked for a favorable report today for House Bill 845. First, I want to mention that I'm a person with lived experience from a family perspective as my mother and dad navigated the process of recovery. As a young person, I witnessed the impacts of shame and stigma as associated with people who use drugs. I did not understand what the recovery process was about, nor did my grandparents. In 2020, I lost my daughter. She had sickle cell disease and was unable to receive access to the necessary services that she needed. I lost my second daughter in 2023. I've been coming here for 5 years advocating for the same exact bill, meeting each one of you. Some of you have been there that long. I'm asking how many and when and how. How can we do this together, collectively behind me? We have peer recovery specialists, we have family members, we have advocates, we have harm reductionists, people who care about the community. We want to place the site here in Baltimore City, but also pilot it in other places. Someone asked earlier today, are we ready? What have we done to raise awareness for the community? We did a guest on our block, things I learned about harm reduction, so much. I traveled to New York. I was able to see On Point, and you're right. You're meted with care and compassion from the front door. Each level was support, also with the service dog that walked us through there. And consumption came at the very last end game of the service, but there was also access to recovery. As a peer recovery support specialist, that's what we do here in Baltimore City. We operate a 24-hour line. If persons want care, we want to give them access. Help us do that. I have lost additional family members since that time. We're in 2025. When and how can we do it? Thank you.
And thank you for coming. I know it's frustrating, but I prayed and hoped that we get there. And I know your voice matters, and I'm sorry about your losses, okay? I'm going to open it up for let's just do the two virtual and then open it up for questions. Ashley Toller, will you please unmute yourself and you can get started.
Hello, Madam Chair and members of the committee. My name is Ashley Toller, and I'm the Policy and Advocacy Manager with Maryland Coalition of Families. Last year, we served nearly 5,000 families of a loved one with a behavioral health challenge, and 15% were families of a loved one with substance use and co-occurring disorders. In the year 2024, we supported a caregiver whose adult child struggled with substance use disorder. This young adult ended up leaving the state, only to shortly be transported back home and buried by her loved ones. Stories like this are only one of many, and she may be here today if an overdose prevention site were available. Overdose prevention sites provide an increased opportunity to life-saving interventions by facilitating connections to support, enhancing access to other systems of care, and providing a safe site to assist in the event of an overdose. This harm reduction approach can aid in improving the well-being and health of an individual in active drug use, as well as reducing stigma many individuals face related to substance use and providing that protective factor of support in meeting people where they are. We urge a favorable report, and thank you for letting me testify today, and that is all.
In here, we appreciate it. Next, please, Ms. Tony.
Hi, good afternoon. Thank you, Madam Chair and Vice Chair Collison and committee members. My name is Tony Torsch. My son died from an overdose in 2010. My family started Maryland's first grief program for those that have lost loved ones to addiction. I'm the director of the Daniel Carl Torsch Foundation and have submitted written testimony. Most of the families that have utilized our grief support program have normally come from Baltimore and Harford counties, and many of their loved ones were found dead on the street, in parks, and in abandoned houses, and they died alone. Can you imagine how compounded their pain is visualizing their children's last moments? This committee in particular has voted and helped pass some really great legislation relating to the opioid overdose crisis. In addition to voting on past budgets that has allowed for organizations such as mine to provide much needed health-centered harm reduction services in probably every jurisdiction in Maryland, as described earlier in others' testimony. And we're finally seeing some results of your careful decisions. In our communities, our boots on the ground teams and treatment providers are doing everything possible now. And we do have some great progress. We've made great progress, but it's still not enough. Delegate Bondari, it was recently released by the Hospital Association that most zip codes in Baltimore County have seen a decline in overdoses coming into the ERs. However, the only one that did not, that rose, was in 21236. We need House Bill 845, and there are people who need it. They don't even know it yet. I'm respectfully requesting a favorable vote on House Bill 845.
Thank you. I'm going to open it up for questions now. Are there any questions for the panel? Delegate Woods.
Thank you, Madam Chair.
welcome.
I want to begin, first of all, just to say thank you for all of your testimony, all of the information that you shared, and that I want to let you know that I think that you're very courageous. And my question is, isn't it time we make this change and do this change, the way we look at things, flip the script so that we can be of people who provide prevention services. Thank you, Madam Chair.
And I thank you, and I want to just say to Tony, thank you for your advocacy, and sorry again, for your loss as well. Any other questions? All right, seeing none, I want to thank you so much for coming and for giving us your personal stories. We really appreciate it. Is Ruth Carlock and Cola Anderson here? Are they here? Anyone that didn't sign up? Okay, before I'm going to end this bill, and I would like to meet you outside, the advocates. I'm going to come out for a minute. My vice chair is going to go on to the next bill that I will call. This actually ends the bill hearing on House Bill 845. Next, we have House Bill 926. Delegate Williams, are you here?
I know they're all like stuck in.
Will you please come up with Jake Whitaker and Robin Elliott, who are your panel, and Vice Chair Collison will take this for a minute while I step out for a second.
Fine. You're good. You're good.
Thank you.
Thank you, Madam Chair. So, House, we're going to let the room settle down just a second. Yeah.
If I may, we have the judiciary with us today. Will you please introduce yourself?
Yes, hi, I'm Delegate Kim Taylor, representing Prince George's County's District 23.
And, all right, so this bill has been jointly assigned. My vice chair has it now.
Thank you, Madam Chair. House Bill 926, Delegate Williams, Healthcare Malpractice Claims, Healthcare Provider Definition. Delegate Williams, welcome to HGO.
Thank you, Vice Chair Collison. Thank you, Chair Pena-Melnick, and thank you to the members of the Health and Government Operations Committee. I'm Delegate Nicole Williams, representing District 22 in Prince George's County, and testifying in favor of House Bill 926, which I would say, I think this is a very simple bill, but that's just my interpretation of it. I think really what we're just trying to do here with this bill is just modifying or really just adding individuals listed under the definition of healthcare provider to include employees, agents, or contractors of a hospital who are licensed, certified, registered, or otherwise authorized to render healthcare services here in Maryland. And that's pretty much the gist of the bill. We're just simply expanding that definition to include additional individuals who administer healthcare services. And by passing this legislation, I think we'll be able to hold more individuals accountable. And so for those reasons, I am urging this committee to give a favorable report to House Bill 926.
Thank you, Delegate. Jake Whitaker, you want to go next?
Great. Thank you, Madam Vice Chair, members of the committee. Jake Whitaker on behalf of Maryland's hospitals and health systems, here to strongly support House Bill 926. As Delegate Williams mentioned, House Bill 926 is just a simple bill that clarifies that claims against all healthcare providers working in hospitals should be filed under the Medical Malpractice Act rather than under the personal injury or wrongful death statutes. And we think it's a very simple cleanup bill that has, and we think that's why there's very little opposition as well. And so I also want to be clear that we don't think that this bill in any way inhibits a patient's ability to file a claim. It simply ensures that all medical professionals are subject to the same legal processes when claims arise from the delivery of medical care. We also feel that this bill is very tightly drafted so that only hospital workers, we all agree our healthcare providers, are subject to medical malpractice claims. So this bill would clarify folks like respiratory care specialists or x-ray technicians or nurse midwives that I think we all can kind of common sense tells us are medical providers and should be considered medical providers under the statute. Additionally, we wanted to make sure that this bill would not include individuals working at hospitals who are not healthcare providers. So for example, folks like security guards or custodial staff. And we drafted it also in a way where it was very narrow. So for example, if a security guard or a custodian assists in stabilizing a behavioral health patient, they would not be considered a healthcare provider for the purposes of filing med mal claims. And that's because we kind of added some language where it basically says that they need to be licensed, registered, or otherwise certified to be able to deliver healthcare services. So not folks like security guards, but folks that come to hospitals every day where their job is to deliver healthcare. And you might be wondering, why are we doing this bill? And I think it's especially critical now because As we all know too well, especially in this committee, Maryland's hospitals and healthcare providers nationwide are dealing with the critical healthcare staffing shortage. And to address this issue, Maryland hospitals are creating innovative new kind of healthcare positions. For example, we worked with some members of this committee to develop the limited scope X-ray technician. And so we just want to make sure that hospitals, when they're trying to be proactive and really address this healthcare crisis, that they aren't punished with additional liability for just trying to do the right thing. So for the aforementioned reasons, we respectfully request a favorable report on House Bill 926. Thanks.
Thank you, Jake. Robin Elliott?
Good afternoon. Robin Elliott here today on behalf of the American College of Nurse Midwives, the Maryland affiliate, in full support of the bill, and thanks to Mr. Whitaker for mentioning nurse midwives who are not currently delineated in the statute. We are supporting this bill because in hospital settings, care is delivered in interdisciplinary care teams. There are nurse midwives, physicians, occupational therapists, full range of behavioral health providers, and we believe that claims should be treated the same for patients and for the providers, all on that care team. So this provides uniformity, and so we very much appreciate that. And as someone who has been in front of HGO multiple times on creating some type of new certification or new licensure, this would also make it clear that the law doesn't have to go back and change every time you do that. So maybe it reduces a volume of legislation by a little bit. So with that, I would ask for a favorable report. Thank you so much.
Thank you. I'll open it up to questions from the committee. No? Okay, I have one, which is if you define them as licensed health care, or is that different from licensed medical professional?
Yes, we tried to use broad language that kind of captured anyone who works in a healthcare profession. So that's why we didn't just do a blanket reference to the health occupations article. For example, we said certified. For example, pharmacy technicians are certified. The limited scope X-ray technicians, they're registered. So we just wanted to make sure that we had catch-all language so that if you weren't necessarily licensed by the health occupations article, you would still be considered a medical provider under this definition.
And would this bill require that all of those individuals actually have malpractice insurance?
I'd have to go back. I know the hospitals obviously have malpractice insurance, but I'd need to double check on the individual providers.
And would the hospital, I'm asking too many questions, but would the hospital's malpractice insurance cover these individuals in this bill?
I believe so, but I would need to double check. Generally, they'll name the hospitals and kind of every party, so I think that's how we'd be implicated as well.
Okay, thank you. Okay, I didn't incite any other questions, so thank you very much for bringing us the bill today and speaking on it. I'm going to call the second panel, which is an unfavorable panel, and that's Deborah Bricado, Patrice Clark, and George Tolley. Is Deborah Bricado here? I don't see her. Okay. All right, well, we'll go with those who are able to stay. So Patrice, you want to start?
Good afternoon, Madam Vice Chair, members of the committee. My name is Patrice Meredith Clark. I am here on behalf of the Maryland Association for Justice. I am also a medical malpractice attorney. I represent victims who have been injured, and I am a constituent of District 31. We urge an unfavorable report on House Bill 926. The Healthcare Malpractice Claims Act imposes special requirements for filing suits against healthcare providers. For example, the Act requires an initial filing to be done in the Healthcare Alternative Dispute Resolution Office of Maryland. I tell my clients we can't even file in the circuit court. We have to go through the Alternative Dispute Resolution Office of Maryland. And that makes sense because we don't want frivolous lawsuits. But the Act also imposes a special cap on the amount of money that victims of medical negligence can recover. And in some cases, the medical malpractice cap is less than half of what can be recovered under the current personal injury cap. So the limits on victims' rights in medical malpractice cases are really quite significant. The Act itself defines healthcare provider very specifically. And as written, this bill would redefine that term to include an employee, agent, or contractor of a hospital who is licensed, certified, registered, or otherwise authorized to render healthcare services in Maryland. But of course, that begs the question, or the questions. What does otherwise authorized mean? Who is doing the authorizing? What does healthcare services mean? That's not a defined term in the code. We just don't know. Really, what House Bill 926 would do would be to allow hospital corporations to unilaterally, by themselves, authorize any or all of their employees, agents, or even contractors to render healthcare services, because it's not a defined term, in an effort to avoid appropriately compensating victims. It's not good legislative policy to indiscriminately shield corporations from the negligence of their employees or their agents or their contractors. For those reasons, we urge an unfavorable report. Thank you very much.
George Tully. Hi, George.
Good afternoon, Madam Vice Chair, members of the Health and Government Operations Committee. It is genuinely, I'm genuinely happy to be here, and thank you for taking my testimony. I'll try to be brief. Ms. Clark covered most of it. I just wanted to address a couple of the questions about the language in the bill. I heard the proponents say it's tightly drafted, and we disagree. We would foresee a lot of litigation over what, who is allowed to authorize, who is otherwise authorized, and were they providing healthcare services. There's not even a limitation that these individuals be providing whatever healthcare services they're providing on the premises of the hospital. So it could be anyone in the field doing community work. And if they're authorized by the hospital, we won't know until potentially it's too late because of the requirements of the Healthcare Malpractice Claims Act. It's very, very important that we know who is and who is not covered by that act before we have to bring a claim in, because we have to go through a separate executive branch agency. So the as drafted, and not to mention also, the folks who would be covered under this bill, they don't have a history like doctors of having difficulty accessing insurance markets. The reason the act exists is because 50 years ago, that was a problem. It isn't a problem anymore. So far as we know, healthcare malpractice insurance is cheaper now than it has been than it was 20 years ago. So these are the concerns that we have, and we ask for an unfavorable report on this bill as it's currently drafted. Thank you very much. I'm happy to answer any questions.
Okay, I'll open it up for questions. Delegate Hill.
Mr. Talley, it's good to see you again.
Good to see you, Delegate Hill.
Is there discussion to be had with the sponsor about potential amendments, or you just object to the bill on its face?
I have been talking with Jake Whitaker about this bill since before session started, and most recently on Monday of this week, because we have concerns about language, and I hear what he wants to do. I didn't see the language of the bill, though, until it was filed, so that we didn't have any input into the way it's drafted currently.
Right. Have you spoken with the sponsor at all?
I dropped by her office today,
Okay.
and spoke with her chief of staff just to be sure I wasn't stepping on any toes showing up here.
Okay, I just asked. Thank you.
Yeah.
Okay, thank you. Delegate Johnson.
Thank you, Madam Chair, and thank you for coming to explain some things to us today. So this bill doesn't directly, but could indirectly impose caps on malpractice claims?
Currently, there are two caps that are relevant to answering your question. There's the original cap, which is in the court's article, section 11-108, which applies to all personal injury actions. About 20 years ago, in a special session, this legislature carved out healthcare claims under the Healthcare Malpractice Claims Act and changed the cap applicable to those claims. So for individuals who are within the act, they have a different cap everyone else, like the janitors and the custodians, if they get in a car accident, there is a cap in 11108 that would cover that claim. What this bill does, in part, is extend the cap that applies to doctors and hospitals and nurses. I mean, I think it's both of us. We believe nurses are covered, and even if they're midwives, they're still nurses. Extends that to cover more people. The objection we have is you're giving, every time you give tort protection to a professional, that down the road may result in an injured person having less access to fair compensation as determined by a jury after a fair and impartial trial. And we're trying to avoid those downstream consequences by keeping the act focused on the people who were in need of help 50 years ago, which are the doctors and the hospitals, and not so much on these ancillary or additional providers. All of that said, we're in conversation with them and trying to understand the need and the scope of the need.
Thanks for the
Did that help?
explanation. Thank you, Madam Chair.
Thank you.
Delegate Tolles, do you have any questions?
Delegate
Taylor.
Delegate Taylor.
Sorry, Delegate Taylor.
I don't have any questions, but I would like to say hello to your panelists. Yeah, we have a bill, the non-economic damages bill, which, I'm trying to make some connection there. I'm not sure how to do it, but if you have any comment on that.
I think that bill is a bill that's been brought a couple of years now. That happens sometimes. We don't know if it's going to move or not. Is there a connection? I think maybe the existence of that bill, although you might ask the hospitals, is one of the reasons they wanted to cover more people under the Health Malpractice Claims Act, because as you know, the bill in your committee currently doesn't do anything to change the cap that protects doctors and hospitals. So that may have been a motivation, it may not have been. I can't speak for them.
Yeah, I mean, the only thing I would say, Delegate Taylor, is that the language of this bill expands the cap this special cap that applies. So if there's no personal injury cap, which is the bill in your committee, then of course corporations want to expand whatever limitation on the rights of injured victims that they can to recover. And that's why we're saying that this is not a narrowly drafted bill. This really applies to anybody who is ancillary to a hospital corporation, which is not necessarily all healthcare providers, of course.
Okay, so another T name, Delegate Tomlinson, do you have any questions?
No, I was just going to say, I haven't heard about this non-economic damages. Please tell me more.
We'll be happy to follow up.
Okay.
Well, I'm happy to touch base with you about a different bill at a different time.
Thank you. Delegate Bagnall.
Thank you, Madam Chair, and thank you. I just want to drill down a little bit because I know that you're just starting those conversations with the bill sponsor, because I think that this is trying to sort of modernize our standard because healthcare is a team sport now, and so we have care coordination teams. So are you going to discuss with the sponsor like how we could sort of drill down on maybe it's the focus on those care coordination teams?
They haven't asked that specific question, but I do want to emphasize that we are genuinely interested in good faith and just to discuss with them the language that they've got, which we have objections to. And if there's a way to make it better that satisfies their goal and that we can live with, that would be the goal of those discussions. I don't know if we're going to get there. I don't predict the future.
And I wouldn't ask for a commitment here, but I did see the bill sponsor nodding her head as well behind you. So I think there is a recognition that maybe we can work together and get to the heart of the matter.
Seeing no further questions. This completes the hearing on House Bill 926. I want to thank our members from Judiciary for joining us today, and thank you for
very
your
much,
time.
Madam Vice Chair.
And
Thank you.
good to see you. We're moving on to the next bill. And this is Bill 812. It's Delegate Gazzoni, Electronic Health Networks and Electronic Medical Record Vendors of Nursing Homes, Release of Records Enforcement. Delegate Gazzoni. I see. Sure. Moving up.
Thank you, Madam Chair. Let me get my right papers out here. Good afternoon, Madam Chair and members of the Health and Government Operations Committee. For the record, I'm Delegate Pam Gazzoni, representing Howard County's District 13, and I'm here in support of House Bill 812 regarding strengthening the requirements around the sharing of electronic medical records with contracted business associates of nursing homes. Some of you may remember this topic from 2023, when assuring access to this data was one of my first bills. That legislation, which was passed, prohibited the blocking of sharing patient information by electronic medical record companies, EMRs, to nursing homes and their business associates. Maryland's law is similar to federal law on this topic, which is known as the 21st Century Cures Act. One might think that the 2023 bill would have taken care of challenges around appropriate sharing of data. Unfortunately, it did not. No explicit enforcement provision was included in that bill, and over the last 2 years, it has become clear that more specificity is needed. HB 812 includes more specific language and a provision which provides a limited private cause of action against an EMR company that is blocking the exchange, the use, or access to protected health information with nursing homes and their partners. I do have a sponsor amendment that you all should have up there that narrows this private cause of action and removes the Office of the Attorney General from an enforcement role. You may also remember from 2023 that Maryland Health Information Exchange, CRISP, has contracted with a vendor, Real-Time Medical Systems, to analyze patient data in the EMR and provide information to the nursing homes, identifying any potential health issues that fall outside of the normal parameters for that patient. The goal of the program is to reduce hospitalizations by keying in on health concerns early, leading to prompt treatment and better outcomes. This program has had measurable success in reducing hospitalizations here in Maryland. Unfortunately, and in violation of both state and federal regulation, EMR companies housing data of the patients in Maryland nursing homes have been involved in blocking the timely sharing of that data. This is not a Maryland-only problem. Since the federal law has been in place, the National Coordinator for Health Information Technology has received over 1,000 claims of information blocking from all over the country. To date, there has been no enforcement action on any of these claims. Further, it's unclear what or if any investigation has been done or will be taken at the federal level to address the complaints. The program in Maryland has been successful in reducing hospitalizations, in keeping our seniors healthier, reducing ED wait times, and keeping health insurance costs down. To maximize those benefits, timely access to the data is necessary. This bill has no fiscal note and will help this successful program be even more successful. I request a favorable report on HB 812. Thank you.
Thank you, Delegate. Who would like to go next?
Sure. Hi, I'm Dr. Scott Rifkin. Thank you, Madam Vice Chairman. Thank you, Delegate Gazzoni, for sponsoring this bill. We all remember 2 years ago when this bill was passed unanimously in both houses, I believe. And the intention was to allow families to choose their own medical team. And also to prevent EMR companies from blocking access to the patient's record for their own financial reasons. Unfortunately, this is still continued as a practice, and I think we've shared with you some of the blockage techniques, at least a little picture of what was going on with blocking the data. I represent the Maryland-based company hired by CRISP to run the CRISP Nursing Home Initiative. The program connects with the medical record system and pulls data to evaluate every single day, every single shift of the year. And I'll give you a quick example. A patient was in the hospital, they broke their hip, they went to the nursing home for 10 to 15 days of therapy to go home. They are on narcotics, they get constipated. they can't have a bowel movement. They end up back in the hospital septic if you don't pick it up quickly. And so if somebody doesn't have a bowel movement in 3 days, this system data mines into the chart, finds those issues, and provides the nursing home with that information. They just don't have enough people to be reading and trying to correlate all this data every day. Last year, we gave 9,000 interventions to Maryland nursing homes. 150 plus of the nursing homes in the state out of 220 participate in the program voluntarily. We reduced hospitalizations, reduced cost. An exactly identical program, it was looked at by the University of Pennsylvania, showing a 52% drop in admissions because of this program, and that was published in the Journal of Managed Care this year. So 2 years ago, this body chose to stop EMR companies from this kind of behavior, and I urge you to support this important bill. Thank you.
Good afternoon, Madam Vice Chair, members of the committee. My name is Celeste Bruce. I am here in support of this bill, also on behalf of RTMS. What I'd like to address for you is some of the activities that we have seen around blocking and why it is so dangerous in this context. You heard a lot of statements earlier. I sat through them from people representing either themselves or on behalf of vulnerable Maryland residents. Folks in nursing homes are some of your most vulnerable Maryland residents. And what we are trying to do is get them real-time health care and use their digitalized medical records in order for the healthcare team to be able to communicate with one another and, as Dr. Rifkin explained, get better outcomes for our residents. When an electronic health vendor platform that hosts these medical records impedes the access, exchange, or use of that information, what is happening is the residents in real time in these facilities are not getting the care that they need. Now, what is important to understand is these vendors, these medical health platform vendors, don't own this information. The patient owns this information. It's the patient's medical record. No different than it used to be when it sat on the end of a bed of a patient in a room. Now it's simply digitalized. Americans, the governments, whether it's state or federal, have spent billions of dollars to digitalize this information for the sole purpose of there being access, exchange, and use of this digital record to the benefit of a Maryland resident and residents throughout the United States and anybody who's getting health care. And anytime you have an entity that is somehow putting up a block to stop you from accessing that information in order to do health care, to provide health care, to be part of the health care team, it's a problem, and that's why this language is necessary in this bill. Thank you.
Thank you.
Thank you, Madam Chair, members of the committee. Bill Castelli on behalf of Real-Time Medical Systems. And I want to talk a little bit about the amendment. The amendment does limit this private cause of action only to the electronic medical record company. You may have seen in the fiscal note some discussion about small business impact, and I can assure you the electronic medical record company is not a small business. But there may be an impact because nursing homes occasionally are small businesses, and to the extent this helps them with patient care, we think is going to be a meaningful impact. The amendments would also address another portion of that law, and that is the current law talks about that information being provided routinely. This would change that information so that that information would be provided immediately. And these are computer systems, electronic systems talking with each other. So there's, there shouldn't be any kind of delay in terms of this information being shared. And because we do get questions about what is the blocking, what is the type of restrictions that we see? You're all familiar with CAPTCHA images that you have to enter when you're going onto a website. I don't have anything on my computer that looks like that. No letter, no number. And that's the kind of stuff that's going on right now. And yet there is no enforcement at the state, no enforcement at the federal. And that's why we're here with a very limited cause of action. And so we would encourage a favorable report.
I'll open it up for questions from the committee. Yeah. Delegate Hill?
Thank you, Delegate Zoning, for this. I don't understand what we're talking about, and I would appreciate if someone could talk to me offline. I don't know if you're talking about someone who doesn't have access to Meditech or doesn't have access to Epic being able to log on and get information, or you're talking about only, I'm totally confused about the specific kind of stuff you're talking about. So I don't want to take up the committee's time, but I'm confused. Thank you.
Happy to do that.
I suspect they'll make themselves available to you, Delegate Hill. Any other questions? I had a question. Given that there are a couple of amendments, is it your sense that these amendments might address the opposition, or you were just fine-tuning the bill?
I would say it addresses some of the concerns that have been raised, but I doubt it addresses any of the concerns of the opposition that will follow us.
Okay. All right. Okay, seeing no further questions, thank you all very much. Thank you for the bill, Delegate, and for your time and testimony. So we have an unfavorable panel, and that's Steve Holt and Luke Pinton.
Good afternoon, Madam Vice Chair.
Pull it close.
How about now?
That's better.
All right, good afternoon, Madam Vice Chair and members of the committee. Luke Pinton of the firm Funk & Bolton here on behalf of Point Click Care in opposition to House Bill 812. Sitting beside me is Steve Holt, VP of Gov Affairs of Point Click Care, the leading technology partner and EHR vendor for SNFs in Maryland and nationally. And before passing it on to Steve, I wanted to share just a few points on the language of the bill. As you've heard before, the bill before you, 812, relates to House Bill 786 of 2023, which established the ability for SNFs to require electronic health record vendors to release patient medical records to SNF business associates, but specifically did not call for private civil enforcement of its provisions. The bill you have before you today establishes an extremely broad right of action by permitting any person, whether directly or indirectly connected to a violating party, to sue for damages, injunctive relief, and for attorney's fees. As introduced, this bill establishes a vague and indirect right of action not currently found elsewhere in the Health General article, and as drafted would likely cause significant confusion in determining who has appropriate standing. We have not yet had an opportunity to see the amendments provided by or mentioned by the proponents. I think we'd be willing to look them over after the hearing. And without further ado, I'd like to turn it over to Mr. Holt beside me, who I think can provide a little bit more detail, but I'm happy to answer any questions.
Good afternoon, Vice Chair Colson, members of the committee. Thank you for the opportunity to be here today and your commitment to long-term care policy and building a sustainable model in the state of Maryland. Like Luke said, I'm Steve Holt, Vice President of Government Affairs with Point Click Care, and here to oppose House Bill 812. Briefly, Point Click Care is the leading technology partner to senior care providers, providing the clinical infrastructure so that care teams can deliver the best care possible for the most vulnerable of patients. We also work closely with health systems like UMS and St. Agnes, ensuring data follows the patient wherever they are on their care journey so that care teams can deliver informed care at the bedside. Now, the sole reason this legislation that you hear today is being proposed is because of a vendor dispute between two entities that is currently being litigated in federal court. The original legislation did not have a private right of action, and it shouldn't have, because health information exchange is federally regulated by the 21st Century Cures Act. This proposed legislation is an attempt to create a conflicting private right of action that is unnecessary and conflicts with federal and Maryland state law. Also, the prior legislation never had any of its rules promulgated. And so having now a private right of action layered on top without any regulations in place and unknown is unnecessary. Now, the exact text of the proposed legislation is equally concerning. Specifically, it states, and I quote, "Entities may bring an action whether the person interacted directly or indirectly," end quote, "with the other entity." To be clear, a lawsuit can be brought without alleging any harm, without any connection to the state of Maryland, and without a single reference to the patient in the entire piece of legislation. As you can imagine, this will require all HIT developers to defend themselves against frivolous lawsuits, all of which will lead to higher costs and zero value to patients. It will inevitably lead to significant patient privacy and security concerns. It lacks any protections for patient safety and access to care that Cures provides. Thank you for your time here today.
Thank you, and I'll open for questions, and I'll start with Delegate Kerr and go to Delegate Hill.
Okay, thank you, Madam Chair. Luke or Steve, probably Steve, I was looking up the Cures Act and the interoperability aspect of it, and it says that it requires healthcare providers, healthcare exchanges, and EHR vendors to share this data securely without unnecessary barriers, essentially promoting seamless exchange of medical records across different systems. How does that relate to what we're talking about here today?
Yeah, that's a great question. And really, when you think about healthcare data at the federal level, you need to think about it in two forms. One that most of us are probably aware of is HIPAA, established in 1996. That's what I would say is really just the protectorate of the data. The 21st Century Cures Act that passed in 2016 is how I would describe the rules of the road is regulated for how data is transferred. And so now, with that, when Congress was delegating that piece of legislation, they outlined how it should all be done, but also recognized that blanket and uniform transfer of data is unsustainable. It would prevent significant issues around patient safety. It would create significant issues around system performance and degradation. It would stifle innovation if you constantly had to open access, open source your technology, your solutions to any vendor that asked for it. So what they did, forward thinking, was established 8 exceptions to the Cures Act. And under those exceptions, there are opportunities for what they call how the information blocking works, but it is done so with the best interests of the public in mind. And so when we think about this piece of legislation at hand, there are actually several instances where it directly conflicts with the Cures Act. Now, one of them, and this was talked about in 2023, was around the fees exception. We've had that conversation in this room, so we don't need to talk about it again today. However, I want to highlight one of the amendments that we heard the proponent shared was the term immediately. That will openly contradict several of the exceptions. First, against security. First, against content and manner. The reason these solutions are in place and these exceptions are in place are to prevent negative outcomes from happening. Last summer, we all watched the news as we saw the Change Healthcare dilemma unfold. That was because there were bad actors that were accessing that system. These exceptions are in place to prevent bad actors from unscrupulously accessing data in order to do whomever they know with it. We're in place to protect those privacy, that security, and make sure those sort of actions do not occur.
Thank you. Thank you, Madam Chair.
Delegate Hill?
Thank you, Madam Chair. Mr. Holt, if I understand your testimony, you're taking issue with the enforcement remedy, and you're taking issue because your claim is that no regulations were ever propagated to follow. But you haven't really addressed what I thought was the underlying thesis of this bill, which is that you're denying access to legitimate entities who have a right
to access it. So explain, other than, there can be a small delay until you make sure the legitimate nursing homes or care providers are trying to access, why are you blocking them? And what are the mechanisms that you're using to block them since they weren't specific?
So the blocking is occurring because there is not a mutual agreed upon security mechanism for that data to flow. What's occurring today is unauthorized bots are accessing our system and mass exfiltrating data out of the platform. And so what we are putting in place are the CAPTCHAs that you saw that are only implemented once our systems recognize that access is occurring at 1, 5, 10,000 times the rate that a nurse can possibly access the system. It is only implemented when there is an opportunity for a bad actor to be identified. And that is the key difference. There are no nurses that have utilized our system that have faced one of those CAPTCHAs. And that is a very key caveat when we talk about accessing the patient data. That is, in fact, the nursing home's data, and it is, in fact, the patient's data. And this legislation does nothing to talk about the patient itself.
May I follow up? So if you said that never happens unless it's at a frequency that would have to be a bot, then what's going on with these 1,000 cases that were cited when legitimate actors were not able to access in a timely way the health data of the residents in their facilities?
Are you by chance referencing the 1,000 claims of information blocking that would go to the OIG under the Cures Act?
Yes.
Those claims could be of literally 50 to 100 different mechanisms to trigger that complaint. All 1,000 of them are not of the same complaint status. So it is not apples to apples in that comparison. And we are of no indication that there has been a formal complaint filed to the OIG on this specific instance. So those are two separate issues that are at hand.
So you're saying that when the nursing homes say they can't access patient data, they're imagining that they can't access it?
We have never once had a nursing home tell us they are not accessing their own data.
Or the patient's data, because it could be, the idea is from another facility. It's not their own data. It's the ability to access the data that a patient has from another facility so they can know what was the nature of the medical care that they received there. That's my understanding.
There's a slight piece that I'd want to change, and it is a third-party technology vendor that is accessing our systems that the senior care facilities contract us to protect and keep that data safe. And there is no handshake and information sharing between the two third-party vendors. The nursing home is accessing all of the data that they need to deliver the best care possible for their patients. What's at hand here today is two technology vendors that cannot come to an agreement on the appropriate data sharing, which is frankly all outlined in federal law under the Cures Act.
All right, thank you, Madam Chair.
Rosenberg?
If other states have had to face this same problem, how have they handled it legislatively?
At this point, there are no other states that have this type of legislation that passed in 2023 on their books. And so this is not something, frankly, that has popped up in other markets that we've had this conversation around, especially around bringing the private right of action for a area of the law that is federally regulated and retains that ability to determine what the right of action would be, because there is an entire enforcement mechanism that is part of the Cures Act. So we've not seen other states go down this path.
Thank you.
All right, seeing no further questions, thank you very much for your time and your testimony. This completes the hearing on House Bill 812. To House Bill 871, Delegate Bagnall, Health Services Cost Review Commission, Community Benefits, Community Health Worker Workforce Program. And Delegate Bagnall, if your panel would come up, that would be terrific.
I didn't write that title. I know it's a mouthful.
Indeed. Okay.
Good afternoon, Madam Chair, members of the Health and Government Operations Committee. For the record, I'm Delegate Heather Bagnall, District 33C, Anne Arundel County, here in proud support of House Bill 871, Health Services Cost Review Commission, Community Benefits, Community Health Worker Workforce Program. You have my written testimony, so I will summarize. Now, you've heard me talk about community health workers before. Community health workers are the key part of Maryland's healthcare workforce, but their work often goes unrecognized. I would argue, as I have before, that we may be the only committee to understand the essential role which community health workers play in our healthcare ecosystem, especially in our efforts to address public health disparities. Because community health workers, they know the people and the services in their communities. They speak the language of their communities, neighborhood by neighborhood, broker trust in the community, and connect their community members with services from preventative screenings and patient education to mental health and recovery services to oral health screenings. Now, community health workers, or CHWs, and community-based organizations, or CBOs, are an essential part of Maryland's public health framework. Through cultural competency and targeted community outreach, they work to facilitate access to social services and bridge the healthcare gap in underserved communities. The data is undeniable. CHWs are effective in improving health outcomes, are an integral part of our overall health system. But in many ways, they still struggle to attain financial support for their work. To provide more formal support for CHWs, House Bill 871 clarifies the eligibility of community-based organizations for community benefit funding and provides a memorandum of understanding framework for partnerships between hospitals and CBOs. There are several requirements included in House Bill 871, Hospital CBO Partnership Framework. One is identifying accountability for patient health outcomes, developing criteria for measuring the impact of a partnership, creating responsibility for recruitment and training, and providing for insurance and other financial benefits as necessary. Nonprofit hospitals are already required to fund community benefit initiatives that address health disparities in the communities they serve. However, community-based organizations may be overlooked as potential recipients. By providing a clear framework for partnership, House Bill 871 encourages greater partnership between hospitals and CBOs, moving us closer to long-term support for CHWs and ensuring community benefit funding flows into the community to ensure better health outcomes in and out of the hospital. Requirements for an MOU also protect CHWs under the hospital CBO partnerships by giving clear guidelines for how funding should be used to support their work and provide greater mobility for CHWs across our entire healthcare continuum. House Bill 871 will provide nonprofit hospitals a clearer way to fund and support Maryland's community health worker workforce through partnerships with community-based organizations and aligns with the goals and pillars of the AHEAD model. This approach will not only benefit CHW workforce, but also allows hospitals to better address social determinants of health in their communities. At the request of stakeholders and to prevent duplication of effort, I have requested a clarifying amendment regarding the impact measurements. I don't have the official language from DLS, so I'll share it with the committee as soon as I have it. And I am aware of the request by the Maryland Hospital Association to change the shall to a may, and we are in discussions to land on the appropriate language to address some outstanding concerns by MHA and also by some of our CBOs. House Bill 871 is an opportunity to help our communities and our healthcare workforce. Leveraging our community benefit dollars just makes sense. With that, I respectfully request a favorable report on House Bill 871, and I will turn it over to my esteemed panel.
All right, great, thank you. Okay. Good afternoon, Vice Chair and members of the committee. My name is Ashley Woolard, and I'm here today as the co-chair of the Community Health Workers Empowerment Coalition of Maryland. You have our written testimony. We're here in strong support of House Bill 871. Maryland is home to the 4th largest CHW workforce in the country, and CHWs act as a bridge that connects patients to care. But they often report the same barrier or pain point to staying in the workforce: the lack of sustainable funding to support long-running careers. Many of them are leaving the field because their work relies on short-term grant funds. HB 871 clarifies that nonprofit hospitals can invest in CHW workforce collaborations with CBOs as an allowable community benefit expenditure. We want to ensure that these conversations lead to the creation of programs that always include discussion of key elements for well-planned program designs that produce measurable positive patient health outcomes and cost savings for our state. The bill leaves ample flexibility for the parties to innovate in meeting community health needs. We feel strongly that our state CHW workforce, who are often working with patients who are uninsured, are not themselves uninsured. HB 871 responds to that concern by making health insurance access a standard requirement to these agreements. You'll see that the fiscal note on this bill is a beautiful zero. That's because the funds for these types of programs come from the hospital's global budget revenue. So they use their revenue and federal funds to support these types of investments. Finally, we understand that the Maryland Hospital Association alluded to the possibility that hospitals may not partner with CBOs if the hospital is providing health insurance and hiring the CHW. We appreciate their support of the overall intention of the bill, but we do respectfully disagree with that point, given that some of the hospitals are already partnering with local CBOs to deliver healthcare services. This committee knows that advancing health equity requires a holistic and collaborative approach, and that's what this bill encourages. Thank you.
Hello. Thank you. Honorable Madam Vice Chair and members of the committee, I'm here to express my full support for HB 871. This bill is a critical step in assuring that CHWs will have the support needed to continue our important work without concerns of losing funding or a grant ending. As a CHW, I have had the privilege of working directly with individuals who face significant barriers to accessing healthcare. The individuals I work with experience a range of competing challenges and priorities, including economic instability, cultural barriers, and chronic health conditions that are often left untreated or undiagnosed. I recently met a gentleman that is living in a tent. He was physically assaulted and suffered injuries that left him with limited ability to use one of his arms. He's not able to work because of this injury and does not feel safe living in a shelter. This gentleman is connected to care at Healthcare for the Homeless and was willing to talk with me. In my role as a supervisor, I see how CHWs can build trust within communities and create meaningful relationships with patients that go beyond clinical encounters. These relationships are so critical for long-term health improvements, as patients are more likely to engage in care when they feel understood and supported. CHWs empower individuals to take control of their health. Building a sustainable CHW workforce is essential. However, for these programs to thrive, we must also ensure that CHWs are compensated fairly and receive benefits that support their well-being. Everyone on my team, including myself, work a part-time in addition to our full-time positions as CHWs. My team and I are committed to the communities we serve, and this keeps us going every day. As a CHW and a supervisor, I strongly urge the committee to pass Bill HB 871. Thank you for your time and consideration.
Thank you. And can you remind us of your name, please?
My name is Lillian Amaya.
Great. Thank you. Excellent testimony. Thank you. Robin?
Good afternoon. I am here today in full support of this bill. The panel did an excellent job. I'm just want to demonstrate how broad the impact of community health workers are, in that we have multiple clients that support this bill, and they cover a wide range of our healthcare system. So these clients include our federally qualified health center organization called Maryland Community Health System, Movable Feast, the Maryland Dental Action Coalition, thank you for the shout out about oral health screenings, the physician assistants, the coordinating center, which provides care coordination for Medicaid waivers, the nurse midwives, they were mentioned in a previous bill, so we've heard a lot about them, and the school-based health centers. So this is a wide range of organizations reflecting the depth at which community health workers can really transform our healthcare system and just how valuable they are. So we very much appreciate a favorable report.
Thank you very much. I'll open it up for questions from the committee. Seeing none, you've done a great job of explaining it. Thank you all for your time and your testimony. Can I have Roberta Richardson and Paul Ellington, please? These are both favorable, if they're still here.
Thank you. My name's Paul Ellington. I'm here on behalf of For All Seasons. For All Seasons is a behavioral health service, and the state designated the only rape crisis center for the 5 counties of the Mid-Shore. We offer services without wait, and if you don't have insurance, you still may see a therapist. We understand the public health situation, the mental health, the public health disparities. We work with everyone from immigrants to veterans to people who just need help. From human trafficking to other things, we see all sides of society, and we understand the value of the community-based organizations and the healthcare workforce. And anything that can be done to help the cooperation improve between the hospitals and the community-based organizations, we certainly support, because we see the shortage every day. And we would certainly urge a favorable report, and thank Delegate Bagnall for standing up for those who often do the work of many but are often overlooked and unheard. So thank you very much.
For being here today. Wait, and let's see if there's any questions. Any questions from the committee? Seeing none, thank you very much for staying and for your time today. Is Roberta Richardson, is she here? Okay. Seeing not, I will go with favorable with amendment. Andrew Nicholas?
Good afternoon, Madam Vice Chair, members of the committee. Good to see you all again. For the record, my name is Andrew Nicholas, representing the Maryland Hospital Association, here supporting this bill with amendments. First, I want to thank the sponsor and the advocates for this bill for reaching out very early to MHA to discuss this bill and engaging with us. I want to echo all of the comments that you've heard from the folks so far regarding the important and valuable work that community health workers provide. It is a very unique and really critical role within the healthcare ecosystem. Hospitals are very supportive of community health workers and efforts to support them, and I know this legislature shares that view. Our amendments, as you heard the sponsor say, are really aimed at wanting to avoid any unintended consequence. As you heard, hospitals already have partnerships with a lot of community-based organizations and specifically supporting community health workers. Worry that if we get too prescriptive in what those agreements look like, it may result in some of those agreements not being formed. And so we want to avoid that potential consequence, but we are continuing to work and meet with the sponsor and the advocates to resolve that issue. Thank you.
Thank you. Thank you for working with the sponsor on this. Any questions? Seeing none, I think we know, and you are going to continue working together, right?
Yes, ma'am.
Get us over the line. Okay, thank you very much. And that concludes the hearing on House Bill 871. And we will go to the next bill. Is Delegate Grammer here? I don't see him. Or his representative. Okay, then we are going to skip 735 and go to, I cannot go to 962. Yes, can we see if Delegate Grammer, okay. We have someone who's reaching out to Delegate Grammer.
We're doing grammar.
Okay. Committee, if you want to stand, don't leave. If you want to stand and stretch, you've been sitting for a while. And you can do that too. You texted, well, yeah, I think he's probably gotten more than one text. I want to thank you all for your patience, those of you who are here today, and in the committee for their good questions, good pointed strategic questions today. I think that Delegate Chisholm did. No. The chair has a bill. I'm not sure. I'm not sure if she's doing it or, okay. We're checking with her. Oh, he is, okay. Delegate Grammer is on his way, and he's here. All right. We are ready to rock and roll, sir. Thank you very much.
Madam Chair, I get the sense you're waiting for me. I'd like to call up my panel if that's okay.
Please do. I think you have Jamie Kavanaugh, Sophia Hamilton, Matthew Mitchell.
Matthew's virtual.
Virtually Chad Reese. Okay,
And I'll get started when you're ready.
and we're ready, go right ahead.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. For the record, Delegate Robin Grammer to present House Bill 735. House Bill 735 removes psychiatric services from Maryland's Certificate of Need laws. I want to start by saying that the more and more I talk to lawmakers from around the state and the more I talk with reform advocates, the more I believe in this bill. The National Health Planning and Resources Development Act of 1974 required states to adopt Certificate of Need laws. The federal government threatened to withhold Medicare and Medicaid funding of states that didn't comply. The argument at the time was to control the cost and ensure access of health care services. After it was found that Certificate of Need laws actually reduced the availability of services, the mandate was repealed in 1987. The Obama, Biden, and Trump administrations have all said the same thing about Certificate of Need laws. They limit new entrants into the market, reducing competition. They lead to higher prices. They fail to improve quality or lower costs, and they encourage lobbying and special interests over patient needs. Certificate of Need laws are needlessly preclusive to the needed expansion and delivery of mental health services. Many states have moved to either greatly reform or even remove Certificate of Need laws. It should be telling that the biggest proponents of the Certificate of Need in Maryland are those organizations with an absolute monopoly on our markets. The one issue we hear about in every committee is mental health and the lack of available beds to service the needs of our state. I found my previous discussions with the HSCRC very formative. Those conversations also reinforced the need to greatly revise this law, as many of the cases in which certificates of need were denied seem to be exceptionally arbitrary. House Bill 735 makes a small but clear change to our Certificate of Need laws by removing psychiatric services from our Certificate of Need scheme. I sincerely believe that if we take the path taken by other states, we would find expanded access with little cost to quality. As the Maryland Psychiatric Society wrote, put simply, Maryland needs more psychiatric beds, and Maryland needs House Bill 735 to facilitate that happening. Thanks for the opportunity to present House Bill 735. I'd be happy to take questions, and I'd ask for a favorable report.
Who'd like to go next?
I'll go, thank you. Madam Vice Chair and members of the committee, my name is Jamie Kavanaugh, and I'm Legal Policy Counsel at Pacific Legal Foundation. I am a policy expert on Certificate of Need laws and have worked with legislators in more than a dozen states reforming and repealing Certificate of Need laws to increase access to health care services. And I want to kind of frame the problem in a way that a Professor Guy Bai at the Johns Hopkins School of Public Health said in addressing Certificate of Need laws. The professor said, the cause for Maryland's ER traffic jam is not that we have too many patients going to the ER, but we allow too few roads to be built. And that's the exact problem with certificate of need laws. We know that there are patients boarding in emergency departments, excuse me, that need access to mental health facilities and mental health services. So this bill provides one solution, one way that will enable new providers to enter the state, but also for existing providers to expand, add beds, add services that they might not already offer. Now, doing this, reporting this bill favorably would be in line with what many states around the country are doing. Since 2019, 7 states have repealed certificate of need for psychiatric facilities and services. And I've submitted written testimony that includes all of the states, but it includes Tennessee, Montana, North Carolina, South Carolina, Georgia, and last year was Oklahoma. And as Delegate Grammer mentioned, actually every presidential administration, beginning with the Reagan administration, has agreed that the mountain of evidence on certificate of need laws shows that they decrease access to care, they increase costs, and they decrease quality of care. We have very good evidence because 40% of the population of the country live in a state with 0 certificate of need laws or very limited certificate of need laws. So we have excellent research from healthcare economists showing the improved outcomes in states that have decided to already repeal their certificate of need laws. So I would urge you to also read my written testimony that was submitted, and I'm happy to stand for questions.
Next, please.
Madam Vice Chair and members of the committee, my name is Sophia Hamilton, and I'm a healthcare policy analyst at Americans for Prosperity, a nationwide grassroots advocacy organization that works to increase opportunities for all Americans. We thank you for your work on HB 735 regarding certificate of need laws. Countless studies have shown that certificate of need or CON laws have been ineffective at their stated purpose, lowering healthcare costs, increasing access to services, and ensuring high quality of care. In practice, CON laws do the opposite. Compared to states without, states with CON laws are associated with higher patient spending, fewer medical facilities, and inferior patient outcomes. Maryland currently regulates 18 broad categories of healthcare facilities, services, and equipment through its CON requirements. According to the Mercatus Center, Marylanders would save an average of $243 a year on healthcare spending in the absence of CON laws. The researchers estimate that Maryland residents would also benefit from an estimated 57 more healthcare facilities and would rate their experiences at hospitals 5% more favorably. There is no doubt that Maryland's CON laws are keeping Marylanders from accessing quality and affordable healthcare. As a resident of the DMV area, I know firsthand how difficult the region's restricted healthcare market makes it to get timely and affordable care at any of our many wonderful healthcare facilities. Despite the region being home to many prestigious healthcare institutions, quality and affordable healthcare that is delivered in a timely manner is hard to come by. As the region's population inevitably increases and ages, the healthcare marketplace will only become further strained, inaccessible, and expensive, especially for the state's most vulnerable populations. The implementation of HB 735 would result in Marylanders and residents of surrounding states having better access to sorely needed mental health services. Americans for Prosperity is appreciative of the reforms proposed in HB 735 and applauds the committee for its important work on this bill. But further action must be taken. Getting rid of the CON requirement for psychiatric facilities and services is a necessary first step, but Marylanders will be left with 17 more CON requirements that will continue to make it more difficult for them to receive quality and affordable health care in a reasonable time frame.
Thank you. We're going to go to our virtual witness, Chad Reese.
Thank you, Madam Chair and members of the committee. I appreciate the opportunity to testify today in support of HB 735. I won't, in the interest of time, repeat many of the excellent points that have already been made by the panel, but I will note, as a senior policy advisor testifying on behalf of the Institute for Justice, that the research on CON laws is perhaps even more damning than has been suggested so far. The Institute for Justice's findings, including a co-authored piece by my former colleague, Jamie, and I think Matt Mitchell, who may be joining us or is unable to, studied 128 different papers that tested the effects of CON laws across the country. And those papers contained more than 400 individual research tests. 89% of those tests show that con laws led to negative or neutral results, and the negative results are 5 times more common than positive results. Frankly, con laws are bad for patients, payers, and they're bad for improving access to care, including and sometimes especially rural care and vulnerable populations. A particular study that may be of interest on psychiatric services specifically found that con laws targeting psychiatric services have up to 20% fewer psychiatric hospitals per 1 million residents and 56% fewer inpatient psychiatric clients per 10,000 residents. That is a lot of numbers reiterating what you've already heard from the rest of the panel. I will say with confidence, this is one of the most extensively studied areas that has a dramatically one-sided set of findings in the literature. This is not a matter of cherry-picking individual studies or individual results with particular authors. The findings have been consistent across states and across time. And as a result, I urge this committee to take the excellent positive first step in con reforms by passing the bill before it today. And I thank you for your time.
Thank you for your testimony. I think, is Matthew Mitchell here? Did he come?
He'll be virtual.
Okay, he wasn't able to make it. So I will open it up to the committee for questions, and I see we have some. I'm going to start with Delegate Bagnall and work my way down. Delegate Morgan and then Delegate Chisholm. Delegate Bagnall?
Thank you, Madam Chair. So Delegate Grammer, I don't see any difference between this bill and House Bill 804 from last year. So given that we convened a work group and determined that there was no certificate of need backlog for expanding psych facilities, I'm wondering why you didn't bring a bill, why you're bringing this bill back rather than bringing a bill to reevaluate CONs writ large.
So I'd like to address the lack of a backlog with certificate of need applications for psychiatric care facilities. And I, talk to providers nearly every day who want to open somewhere and tell me they will avoid certificate of need states. So the lack of a backlog isn't the main indication that there aren't enough services. I think the backlogs in the emergency departments are the indication that there aren't enough services. And the other problem with certificate of need laws is that the whole procedure advantages existing providers. So anyone who wants to come in and provide something innovative, something for a niche population, something culturally, something tailored to a cultural competency, can't afford to take the risk of time and money to go through the certificate of need application process. So it's very understandable why many of these providers say I'm going to Colorado or California where I don't have to go through a certificate of need process.
I did, and I appreciate that, but very respectfully, we actually convened a work group on this specific issue, and we could find no one who actually raised their hand and said that this is the reason that we're not coming to Maryland. So I'm just wondering, again, Delegate, if it's certificate of need, and that is perhaps something that we should consider, why not bring a bill that actually looks at certificate of need writ large?
Well, I think the question is, why are we going to, the gentleman, Mr. Reese, said this is one of the most studied sections of policy, and specifically mental health has found disproportionately lopsided and favorable statistics. So, I was part of those work groups. I appreciate the chair making me part of those work groups. I think they reiterate the need to get rid of certificate of need laws. I think, Ms. Kavanaugh joined me and she made a great case, and the opponents, frankly, didn't make any case at all. So I think, having a bill every year, kicking this can down the road to have a work group, I think the time for expanded access to mental health services is now. I think this is the one issue you hear about in every single committee in this body, from judiciary to appropriations to health and government operations. We passed a bill, it was on third reader on the floor, dictating to providers what they have to do because there aren't actually enough mental health facilities in certain areas of the state. So we have to start to statutorily fix how providers provide coverage for all plan mental health facilities. So, I mean, I think that the burden of proof here, frankly, is on the handful of providers in the state who have an utter monopoly. I mean, let's keep it real here. It's Shepherd Pratt and Johns Hopkins and the University of Maryland. Those are the only people opposing this at all. So I think the people of the state are screaming for increased access. You know, I think this committee has shown leadership in advancing this issue, and I think the facts and statistics nationwide show that this is the correct path. And this bill, which is 2 brackets, you know, I love simple bills that have a big impact. So I don't think we need to overthink this. I don't think we need, you know, another 3 years of studying, and I think the facts are on our side, and I think the time to act is now.
All right, thank you. Delegate Morgan?
Madam Chair, thank you for the bill, Delegate. I think the majority of people in this committee are familiar with certificate of need laws, as well as like self-referral laws. All of those laws exist not to duplicate services, and really probably is a barrier for increasing more providers. You want to talk about the benefits of the states that had the courage to already do this, and what's maybe some of their experience has been?
Yes, thank you for the question, Delegate Morgan. So let's talk about South Carolina. In 2023, South Carolina repealed all of its certificate of need laws except nursing homes, and did so. The House voted unanimously there. It was a bipartisan issue. It went back to the Senate for a concurrence. It was passed unanimously there. One of the very first projects that was announced in South Carolina following that repeal was a juvenile mental health facility that's being developed now. So it's very exciting to see. Another benefit we've seen in Florida are a huge amount of gains in mental health beds since Florida repealed most of its certificate of need laws. They did that in 2019. Most of the laws became effective 2021, so we have data from there. And people worry that the growth might outpace the need if everyone's allowed to open. And actually what we've found looking at Florida is that the growth just kept up with the population. So the change was needed to allow facilities to expand, to have the appropriate level of care for the state, but the development didn't happen in a way that overran the industry or something like that.
Brief follow-up. Something just dawned on me when you were asking that, and I'm not sure if this question is appropriate for the hearing. Maybe it is in subcommittee. But those that would approve the certificate of need, I believe that's a board of dealing with mental health. Are the people that oppose this bill staffed with the same people that would also approve the certificate of need?
If I'm not mistaken, the answer to that question is yes. And it really becomes a conflict of interest. You know, is there any other industry where the people who have the current market share get to step in and testify against their competition? If you're Shepherd Pratt, who has 380 providers in the state, you're familiar with the state lobbyist, you know, who to hire to advocate for you. You swoop in, a mom and pop shop wants to open up one provider, and you can, you know, there's no chance for them. So I think you really have a huge point here in that it's a process that is completely unfair and is completely set up to maintain the monopoly that's in place to the detriment of all of our constituents.
Yeah, appreciate it. Thank you. Thank you, Madam Chair.
I think that Delegate Chisholm's and Delegate Szeliga's question got answered, asked and answered? No? Oh, wow. I didn't do it. Delegate Chisholm.
Chair. Delegate Grammer, you've obviously worked on this bill for at least, I think, the last 3 years, maybe the last couple of years.
Sure.
So in your research of looking at this, and I don't want you to be a fortune teller, but if we did not have a certificate of need law in the state of Maryland today, do you have any idea how much the access would be expanded? Do you have any statistics or numbers you can share that you think employee-wise, one, and two, people that would now be able to receive access to care?
I'll defer.
Thank you for the question. Well, since we can compare what happens in states that have already repealed certificate of need laws, we know that more providers open for business. I don't have an exact number. Ms. Hamilton shared some numbers from a study that did look at Maryland specifically and estimated, I think she said, an additional 55 facilities within the state. And I do want to caution, of course, this new development, if certificate of need went away, isn't all going to happen overnight. It's still a big business investment, but this is paving the way to allow more providers to come in. But we don't have to guess about what would happen because we can see easily in the states that have done it. And one other thing I'd like to mention, because you mentioned employees, is that by restricting the number of facilities you have in your state, you restrict the places where students can do clinical training. The American Association of Nursing Colleges said in 2023, it turned away 66,000 qualified applicants, that's qualified applicants, in part due to lack of clinical space. So allowing more spaces to open will also allow more staff to train, more people will be interested in going into these jobs because they'll see interesting, viable employment options.
And I'll ask my panel to share their statistics with the committee.
That'd be outstanding. Thank you, Delegate. Thank you. Thank you, Madam Chair.
Thank you, Madam Vice Chair, I guess, now that the chair's here. Thank you for bringing this bill. I want to let you address the Maryland Healthcare Commission's opposition to the bill. They say the certificate of need process provides critical regulatory oversight to ensure the proposed healthcare facilities have the expertise and capabilities to provide high-quality services. Would you say then if a provider came in, they would still have to follow Maryland regulations other than the certificate of need? I'm assuming that's what happened in the other states.
Yeah. So this is a huge point. It's a bit of a red herring that you hear thrown out every single time that someone questions certificate of need laws. Quality of care is oversaw by the regulatory framework that we have for everything in the healthcare system. This bill does not change that whatsoever. So any regulations or statute that we have that governs the quality of care will not be changed whatsoever. What we're focused on here exclusively is the process by which a new provider can just try to enter the market. So it's a little bit frustrating, but when everyone from Barack Obama to Joe Biden to President Trump agree that on this issue, quality of care is not enhanced, and in some cases, certificate of need laws are to the detriment to the quality of care. When the statistics are on our side, I think we can rest assured that quality of care will be protected by the regulatory and statutory framework we have that protect that.
And one more follow-up, if that's all right. Additionally, in their testimony, they talk about the number of beds, psychiatric bed capacity. They talk about acute care hospitals and private psychiatric hospitals. So you add all those numbers up. It's only two categories. And you get 1,322 psychiatric beds for the entire state of Maryland.
It's terrible.
So what have you seen in other states?
I kind of want to defer to Mr. Reese because he had some good statistics. Chad, are you okay to respond to that question?
Sure, and unfortunately, I don't have a state-by-state breakdown in front of me. One example that might be illustrative here, and it gets to one of the points that Ms. Kavanaugh mentioned earlier about the characteristics of some of these facilities. The Institute for Justice actually represented a couple of healthcare entrepreneurs who wanted to provide healthcare services in the state of Kentucky, but were foiled by the certificate of need process there. And what they specifically wanted to do was open a small 30 to 45 patient facility for the Nepalese population. So I bring up this for a couple of reasons. One, to represent that, to Jamie's point earlier, some of these facilities will be so small that the burden of going through the certificate of need is overwhelming and they never apply anyway, which is why you don't see the backlog and why you don't see the denials show up like you think you might. but also that it's very difficult to sort of sit back at an agency level and predict the actual needs of various communities. No one at the state level of Kentucky realized that there was a need for a 30 to 45 patient facility of Nepalese individuals in the Louisville, Kentucky area. And those are the kinds of predictions that are very difficult to make, standing aside. The one thing that I can tell you from my testimony is the one study that specifically looked at the psychiatric services in states with con laws versus those without. And those states with con laws for psychiatric services have up to 20% fewer psychiatric hospitals per 1 million residents and 56% fewer inpatient psychiatric clients per 10,000. So that's an average number. We can't be exactly sure what that would look like in Maryland specifically, but that's a good benchmark for what the shortfall between con and non-con law states look like in that regard.
Thank you. I would just also note that the letter says that they're only 85% staffed, but, you know, and it seems like apples to oranges. You know, if you have a small company that wants to start something like that, they would staff it themselves and, you know, find a way creatively to do that. So I found that a bit of a red herring as well. Thank you.
Thank you. And thank you for being here today and providing me your testimony. I appreciate it. I have a question for Ms. Jamie Kavanaugh. Can you tell me a little bit about Pacific Legal Foundation? Can you tell me what your mission statement is?
Yes, Pacific Legal Foundation is a national public interest nonprofit. Most of what we do is civil liberties litigation. We work to protect the right to economic opportunity. We protect private property rights. We also represent people trying to open innovative healthcare services that are being foiled by certificate of need around the country. And then we have a small policy arm that works with legislators like yourselves so that we can change the laws and avoid suing you, so we can make the laws better through this process.
So I have also a question for, is it Sophia Hamilton? Ms. Sophia Hamilton, and thank you for coming here. You said that no one bothers to apply, right? Because when you're trying to fix a problem, you try to see what is the problem, right? What is it that we're trying to fix? How can we fix a problem when we don't have someone in Maryland that has been denied that application?
Yes, Madam Chair, I think that was actually Ms. Kavanaugh that made that comment, but I can speak to it. So individuals are not going through the application process because it is so lengthy and expensive, because you have to get lawyers to fill out this application with you, and then you can get the application can be stopped by your competition, who some of which sit on the board that approves these applications. And so that's why so many people aren't going in and filling out the application itself. I've spoken to many doctors in the area who have practices in Virginia and DC, but don't practice in Maryland because they know that it's too difficult to get that application for their specific services.
Can you do me a favor? Can you give me a list?
Oh, I'd love to. I can definitely connect you with those providers.
Yeah, I'd like you to send me an email with that list of people that have actually applied for CON in Maryland and have been denied. I like a list of those people.
The complication here is not everyone is applying because they know that it is too difficult to get the application, and it is not worth their time as a business to make that investment into an application that may likely be denied.
But you said not everyone is applying, which means that someone is applying. So I'd like to know who is applying that has been denied, please. Thank you so much. That's it.
Rosenberg.
This question's for either expert. Did your research include the expected impact of what's widely seen as a major cut in Medicaid by the Congress? What effect that would have on the provision of health care in Maryland?
I can speak to what the research says. No, I don't have any specific study on that, but what I do have is that hospitals, safety net hospitals in states that have already repealed certificate of need laws have better margins.
This is about Medicaid.
Sure, and safety net hospitals are providing majority care to majority Medicare, Medicaid patients. Sorry that I didn't explain that. So these hospitals that are providing care to mostly government-insured patients have higher margins, are doing better, are staying afloat better in states that have already repealed their certificate of need laws. Dr. Mitchell, who couldn't join us today for testimony but wanted to, has looked at all of the different tests of certificate of need law. And when we look specifically at underserved and vulnerable populations, we find that there are 0 tests that find any positive impact from certificate of need laws.
Well, what about the impact of a reduction in Medicaid? Forget the issue of certificate of need for purposes of my question.
Sure, so I think this question, I get this a lot. It has to do with the cross-subsidization that happens between privately insured patients and government-insured patients, and the hospitals argue that they rely on this to stay open. And this is called cost shifting in economist terms, so I can send you papers on that. And the economists, these are economists from Congressional Budget Office, from different states around the country, because hospitals make this argument anytime any law is going to change and affect their bottom lines. And Congress especially wanted to find out, is this what's really happening if the payer mix changes, are the hospitals going to close? And all of the evidence shows that no, there is no reliance on cost shifting in the way that the hospitals argue. And in fact, lots of hospitals that are majority Medicare, Medicaid can still be profitable. Now, how they studied this is very interesting, is by looking at if hospitals had to make up their shortfalls for government-insured patients, then when government rates go down, Medicaid rates go down, hospitals would be forced to increase their rates against privately insured patients. But what all these studies found was the exact opposite. Actually, when government rates went down, the rates for privately insured patients also went down. So there wasn't this reliance, there wasn't any connection in the way that's often argued. So I think that's what you're asking about.
Thank you.
Okay. And I am going to make an executive decision and allow the chair to have another question.
It's good to be the chair.
Thank you very much. I'll take one of Delegate Hill's questions. I'm sure everybody here appreciates it. And actually, this is just a follow-up on Delegate Rosenberg's question. I know that you said that you represent, people, and I saw your mission statement online, and you sued and you win cases. Will your organization consider suing the federal government because 36 million people are at risk of losing their Medicaid? That is really, 36 million people are at risk. I think that is worth doing. Is your organization considering doing that?
We are not. We typically represent business owners that want to provide solutions to their own communities.
Okay, thank you so much.
Okay. All right, seeing no further questions for this panel, thank you all very much.
Thank you so much.
Thank you, Delegate, for bringing us the bill. In the interest of balance, I'm going to call an unfavorable panel, and that's Winnie Hawk, David Sharp, Damian Lang, and Yarama Shah Taylor. David, you want to get started?
Sure.
Okay.
Okay. Good afternoon, Madam Chair, Vice Chair, members of the committee. For the record, my name is David Sharp, and I am the Acting Executive Director for the Maryland Healthcare Commission. It is a pleasure to present MHCC's position on the bill today. Joining me, as noted by the Vice Chair, is Winnie Hawk, who's the Director of the Center for Healthcare Facilities Planning and Development, and Yarama Shaw Taylor, Chief of the Certificate of Need Division. The MHCC opposes House Bill 735. The importance of Certificate of Need process cannot be overstated. It plays a critical role in shaping the delivery of healthcare services in Maryland. The Certificate of Need ensures that healthcare services and facilities are developed based on community needs, preventing unnecessary duplication of resources while promoting cost-effective, high-quality, and equitably distributed care. It also provides essential regulatory oversight to ensure that proposed healthcare facilities have the expertise and capabilities to deliver quality of services needed in the specific geographic area, and that the proposed projects are financially viable. We acknowledge the critical need for additional behavioral health care options in Maryland. It is important that efforts to expand these services be carefully considered to avoid unintended consequences, particularly for the state's most vulnerable populations. These individuals rely on the state's rigorous vetting process to ensure that new projects align with healthcare goals and maintain the quality of services that are essential for their well-being. Chair Pena-Melnick, Vice Chair Cullison, members of this committee, this concludes my testimony, and I invite my colleagues now to provide additional details on our position and rationale. Thank you for your time and consideration, and with that, I'll turn to Ms. Hawk.
Thank you. Thank you, David. For the record, Winnie Hawk, the Director for Healthcare Facilities Planning and Development for the Maryland Healthcare Commission. And David has articulated, why the general global reasons why certificate of need is important. And you have our position paper, and I don't need to go over that, but I want to emphasize 3 major points. The first point is capacity. Capacity has grown. When I say capacity has grown, I'm saying acute psychiatric bed capacity has grown in Maryland. However, staffing is insufficient. In the past 5 years, we have added 200, a little over 200 acute psychiatric beds. So that breaks down into about 120 beds for acute hospitals and another like 85 for the private psychiatric hospitals, but only 85% of those beds are staffed. Back when the regulations were updated for acute psychiatric services in 2021. At that time, stakeholders' feedback during that process, it was that there was not a shortage of psychiatric beds generally, but there's a shortage for specific subsets of patients, especially those with resource-intensive needs, specialized needs, or secondary diagnoses, developmental delays, or aggressive behavior. The Maryland Healthcare Commission, we believe that the need could be met by existing facilities if all the beds could be staffed, or if more facilities had the resources required to manage the more difficult psychiatric patients. In terms of allowing the establishment of additional capacity under this bill, we believe it could make it difficult for existing facilities as well as the new facilities to succeed because they would all be competing over the same resources, which is staffing. Real briefly, we don't believe CON is a barrier. In the last 10 years, only 1 project has been denied. We have approved 3 psychiatric hospitals in counties across the state, and over the last 10 years, we've added 300 beds. Again, it goes back to staffing. And then very briefly, the CON process. We mentioned this last year, and we also mentioned it in the work group in the interim. The CON process has been streamlined. We have accelerated the timeframes for the reviews. We've reduced the scope of interested parties that can get involved, and we have streamlined the post-approval reporting requirements. And since those regs have changed, the 2 projects we have approved have been reviewed and approved within 4 and 5 months. There are only 2 projects. They didn't involve psychiatric bed capacity, but it's just showing you that the streamlined regulations are working.
Okay, we're going to.
And I'll wrap up with that, and I'll ask for.
We have your written testimony, is
Yes.
that right? Okay, thank you.
Yes.
Damien?
I'll turn it over to my Arama, who is the chief of the
Arama,
certificate
okay.
of need.
Good afternoon, committee. One thing that we also want to add is that there are other measures in place to look at larger aspects of psychiatric bed capacity, and one of those is the emergency room wait times. Last year, House Bill 1143 was passed, And this House bill is for Maryland Emergency Department Wait Time Reduction Commission. Part of that commission's charge is to develop strategies and initiatives to reduce wait times. This includes assessments and review of behavioral health and expanding behavioral health framework. A big part of expanding that behavioral health framework is adequate staffing. And if the committee is given the time to review comprehensively, then we can present the information from that committee. The first report is due November 1st, 2025, and then the full report will be due November 2nd, 2026. So given that time, and Winnie Hawk is a member of that committee, if given that time to review part of the emergency room wait time, which we believe will find that has to do with staffing at emergency rooms, psychiatric staff, and the like, then it'll make a greater case for that. It's the staffing that is a detriment to psychiatric capacity. Again, the MHCC urges the committee to oppose House Bill 735, and we ask for an unfavorable report for House Bill 735.
Okay. Thank you. Damien?
Good afternoon, everyone. My name is Damian Lang. I'm the State Government Relations Director for Shepherd Pratt. I don't want to repeat anything that my fellow panelists have said, and you all have a copy of my written testimony, so I just want to touch upon a few points that came up during the sponsors panel. First, removing CON is not a silver bullet to the behavioral health crisis in Maryland. It does nothing to actually address underlying structural challenges that we have. We need high quality care, and we need a full continuum of that care. It's not just more beds. It's expanding step down to community-based care. It's addressing the behavioral health and mental health workforce shortage, and it's increasing reimbursement rates. That's actually going to help access in our state. To touch upon two of the examples that came up in the sponsors panel, looking at other states that have removed CON laws, Florida and South Carolina, let's look at what happened there. For-profit psych hospitals refuse to accept Medicaid and uninsured patients. They refuse to they take low-risk patients, leaving the most complex cases to nonprofits. And they prioritize short-term stabilization over long-term recovery, which actually helps people. This is a market-driven disparity brought into these states by the removal of CON laws. The benefits are dubious at best, but what is proven is that there is instability into an area that severely needs high-quality care. So there are a lot of unintended consequences that I think we can avoid. And lastly, I just want to touch upon the board that approves CON, saying that we have providers who are on that board and are, you know, voicing their opinions on these boards is just patently false. That doesn't happen. Providers like Shepherd Pratt, we can submit testimony, but we're not making these decisions ultimately for CONs to be approved or denied. People aren't applying for CON. That's not the issue. It's not a case of denial. So thank you. That's all.
Thank you. That's everyone on the panel, right? So I'll open for questions, and I'm going to start with Delegate Salega, and then we'll go to Delegate Morgan.
Thank you. I'm making room for my friend here. Hey, I was wondering, so I have been involved in one CON, and that was, Winnie, you'll know, the Harper County one. And it was a debacle, frankly. I mean, how many years did that take? And how much money did it cost to do that? So I think it would be nice if we would know how many years it takes for an applicant to get a CON, and how much money does it cost to make that happen? And then I don't expect you to have that on the, top of your mind at this moment. But when I think the supporters of this bill said that people aren't applying, I think when that data becomes clear, you'll see why. It's shutting possible applicants out when you know it takes, how many years did that Harper County take? Do you know, Winnie?
I would have to look that up.
5 years? Delegate Riley and I think it was 5 years. So what possible private business could sustain a 5-year application process? So I think that's what we're seeing, and I'm a little bit puzzled why you wouldn't think that opening the market up to allow others that want to provide this much needed and essential service for our citizens would be a bad idea, other than, you know, what you've already said, in light of them saying, you know, it's competition.
But I believe healthcare is not typical. It's not a typical type of business that it lends itself well to competition. For example, in an emergency situation, in an emergency situation, a patient is not going to shop around, right?
Well,
and you open it up to competition. How are we going to guarantee access to rural areas? Because access is a key point. How are we going to not have the competitors siphon off the quite frankly, the high reimbursable services from a hospital, when a hospital is also going to be taking your uncompensated care and in their emergency department? So how do you stop the cherry picking?
Yeah, I don't think that's what the data shows happened in other states, but I would challenge you right now. We're not doing a good job of providing these beds in rural areas today, and that's why we're having this conversation, because 1,322 beds for an entire state is inadequate. And I understand your challenges with staffing. I get that. But, you know, saying because we can't find enough staff to staff the beds, we're not going to let anybody else open up. These other people may have, you know, bring with them some staff. The Nepalese, I mean, that was a great example. So I would just ask you all to maybe have an open mind and think about this, and we will provide you with their data. Okay. Thank you.
Delegate Morgan.
Thank you, Madam Chair. I just wanted to piggyback a little bit on the competition question. With healthcare, I'm wondering why you think healthcare is different than any other service. And I'll give you a very good example for healthcare. LASIK surgery. LASIK surgery used to be like $10,000 an eye. And now the price has plummeted, and there's tons of people that offer LASIKs because it's not regulated and you don't need a certificate of need. So my question for you is, how would you solve this problem of more mental health and bringing more service providers into the area?
I think, let me just state that there are 15 hospitals in this state that do not have that do not offer psychiatric services. I said, I'm sorry, not all hospitals offer psychiatric services, acute inpatient psych services. So that could possibly be a solution if you want them to be geographically situated, I mean, around the state, number one. We have looked at, we have a regulatory mechanism that we used during COVID, and it was the Emergency Certificate of Need process. And we did, when we presented to the work group in the interim, that was one of the options that we put on the table. And that would allow an entity to apply for beds. I think the standard is to address a public health emergency and that cannot be delayed. So you simply apply for the ECON and you get it immediately on a decision of the executive director. Then it goes to the next commission meeting, and then until that emergency has ended. And we offered that, and we thought, I mean, that is an existing opportunity right now.
And I might add, Delegate, that if you want to bring the workforce, you want to bring additional workforce to the area, reimbursement rates are something that have to be looked at, because for behavioral health, they're all very, very low. And so what happens is providers aren't staying in the state. They're going elsewhere. They're doing telehealth in other states. They're not moving to Maryland.
So you're telling me there's healthcare, mental health care workers that are leaving Maryland because they're fleeing to another state that might be less regulated?
So I wouldn't say they're fleeing Maryland. I would say what happens is they're seeking to work across state lines because they're getting more money via telehealth than they would be if they were providing in-state services.
Thank you, Madam Chair. I won't belabor the point.
Delegate Johnson.
Thank you, Madam Chair. The question is for Ms. Hawk. You said that you have approved 3 new facilities. Were those in addition to, or were those 3 new facilities because other facilities closed? And were those mental health facilities?
In terms of are you talking about since the certificate of need regulations have been streamlined, or?
You mentioned that we've opened 3 new facilities.
Oh, well, that was in the review of what we have done in terms of acute psychiatric bed capacity. In the course of the last 10 years, 5 years actually, we have approved 3 separate facilities, correct? That's the part of the 200 bed count that I referred to.
And were those 3 new additional facilities to Maryland, or were those because other facilities closed? And were those behavioral health facilities?
They were behavioral health and they were new facilities.
Okay, all right, thank you.
Questions for, Delegate Hale.
I tried. Here's the question. You were saying that it's primarily a bed problem, and that you thought the expedited certificate of need process works best. But I think what the sponsor is arguing is that even if it's a workforce problem, anyone who would want to apply will take that on their own. And if they can't find the workforce, they wouldn't be applying for it. So they're taking on the responsibility of providing a workforce. So could you explain what makes the expedited process you think so much better than the process that we used to use? And why you wouldn't count on the person applying or opening up a business without a certificate of need of knowing there's a workforce issue and going forward in the business or in the service because they think they can handle that workforce issue?
Well, in terms of the emergency certificate of need process, I just don't think that has been contemplated for this situation because of what I believe is this growing issue of emergency department wait times because there's lack of capacity. So I think we have thought through what can we do to add bed capacity in an expedited manner, and this is a way to do it. So that's I think that answers your question. You can add the capacity immediately given the situation.
And what are the steps? I mean, the steps that make it so much shorter is you just say you want it? I mean, what is that? You simply, I'm looking at the regs now, it's up to the executive director to issue it's called an ECON, and the procedure is that they send a letter and they explain what the immediate public health emergency is, and whether it's, we have no capacity, which is what they did in COVID, and you were able, if you had the space, you could add the beds, and some facilities even added satellite space, and so that's that. So you don't have to wait. Ultimately, when the crisis is over, or the emergency is over, what happened in COVID is that those facilities that wanted to keep the beds, then, they didn't have to stop serving those patients, but if they wanted to keep them, they ultimately applied for a certificate. So even without this legislation, you're saying that is available if people want to open up psychiatric beds now?
Yes.
Okay, thank you.
Thank you. Now, seeing no further questions for this panel, thank you very much for your time and your testimony and your patience today. We have a couple more favorable witnesses and information on this bill. If we'll bring Matthew Mitchell up virtually, and then to the table, please, Debbie Jennings, if she's still here. Paul Ellington. Is Debbie Jennings here? Paul Ellington? Okay, then we'll start with Mr. Mitchell. He was there. There is she's virtual too. Is Johanna Da Silva Gonzalez in the waiting list? She never came? Okay. Here he comes. Now we're talking. Hello, Mr. Mitchell. Go ahead when you're ready.
This is so kind of you. I was moving on. I had no idea that you were going to invite me back. This is so nice.
I'm missing the tie, though.
Thank you. Thank you so much.
Please go ahead and start.
Okay, thank you. I'll be brief here. So my name is Matthew Mitchell. I'm an economist and a senior fellow at the Need Regulatory Research Center. I've been studying certificate of need for about a decade now. And I just wanted to share with you a little bit of what we've learned through the systematic study of these laws. So one of the things that's interesting about certificate of need laws is the way that they have evolved. We now are in a position where about half or about 4 in 10 Americans live in a state with either no or very limited certificate of need laws. And so we can compare what's going on in those states to states that have significant laws, significant certificate of need laws. And what, as it turns out, this has been an extraordinarily well-studied topic. So there are 146 peer-reviewed studies of certificate of need laws, and these are by academics who are not, don't have a stake in the issue. And together, these contain well over 400 tests, empirical tests where they're assessing what happens to outcomes for patients. And the evidence, I've recently reviewed this in a Southern Economics Journal article, and the evidence is quite clear that certificate of need laws just don't work as intended. We don't have to speculate about what would happen. We can look at the real world and see what's going on. So just for example, just to take a few examples. So for example, certificate of need laws are intended to restrain spending. For every one test that says that they do that, there are 9 papers, 9 tests saying, nope, they actually lead to higher spending. If you look at access, for every one paper that says certificate of need laws increased access, there are 10 that say no, it undermines access. If you look at quality, the ratio there is about 1 to 3. If you look at underserved populations, and this is really kind of what I wanted to highlight here, since we're talking about a law that, or a particular certificate of need that limits care to underserved populations, it's zero evidence that it increases care for underserved populations. Thank you so much for your time. I really appreciate it.
Thank you. Are there questions for this witness? Delegate Salega.
Thank you, Madam Chair. Could you tell us, we heard testimony from the opponents that when these private, let's say, facilities or hospitals or patient beds open, it cherry picks the private pay and, leaves the state, with the government health insurance folks. What is your research found on that?
Yeah, that's a great question, and it's a relatively common assertion. There is no evidence of that. So if you would expect this cherry picking problem to be a significant issue, then what would happen is once certificate of need laws go away, then you would see an influx of ASCs and then hospitals close. You see the first, but you don't see the second. There is no evidence of greater hospital closures in states that remove certificate of need laws relative to states that don't. There was a recent paper by Thomas Stratman and several others in the Southern Economic Journal that looks at that very question. The other thing is that if you would expect, if that were true, you would expect to see, for example, safety net hospitals in states with certificate of need laws to have higher margins. They actually have lower margins. And the final thing I'd add is that this is kind of a convoluted way to do it. If you want, Peter, if you're worried that Peter is not going to get care, giving a monopoly to Paul in hopes that he charges Mary more for her knee replacement and then somehow offers more care to Peter, it's a very convoluted way to do it. A much more straightforward way to do it is just to have the public support the care for indigent care. But we don't see any evidence that certificate of need laws actually help in the provision of indigent care or safety net hospitals or any of that.
Thank you.
Okay, thank you. Seeing no further questions, thank you very much for your patience, Mr. Mitchell. I know you were hanging around for a while.
That's so kind, thank you.
So that concludes the hearing on House Bill 735. We are going to start the last bill of the day, which is House Bill 962, Delegate Pena-Melnick, and I will turn the chair back over to her as well.
Thank you, and I want to thank everyone for being patient as we take on this bill. But before I start, I would like to welcome the Appropriations Committee. Will you please take a minute and introduce yourselves?
Thank you, Madam Chair. Hello again, friends in HGO. We've got the Health and Social Services Subcommittee, 3 of us here to join you for Pediatric Overstay. I'm Chair Emily Shetty from that subcommittee, and we are joined by Delegate Alethea McCaskill and Delegate Jim Heinbaum. Yes, thank you.
Wonderful. So as you know, we do a lot of the policy work, so does Chair Chetty, and they have their appropriations, so they decide, they have a tough job deciding on the budget and the policies to fund. And I am really grateful that they're here today to listen to House Bill 962. And I am going to and I want to thank those of you that are sitting the panel and everyone that is trying to work on this issue. House Bill 962 is basically public health pediatric hospital overstay patients. So what is it? So this is a problem, and I'm going to be blunt. Right now across Maryland, children and youth are trapped in hospital emergency departments and inpatient units, not because they need to be there. Oftentimes there's no medical need. These are foster children. But because we have failed to provide them with the appropriate care setting in the community that they desperately need. These are children in crisis, stuck in limbo, waiting for help that is not coming fast enough for them. Can you imagine your children, your loved one, your family member being stuck in a hospital simply because there's nowhere for them to be placed, nowhere for them to go? I want you to think about this. Think about that child who's in that hospital, who doesn't get to go outside to play, who's in that hospital where the lighting is not pleasant, where the noise is not pleasant, where there's strangers around them, where they cannot even play with their peers, where they cannot go to school, where they're falling behind in school, where they don't see a loved one that can give them a hug, some understanding, some love. Our children deserve better. And the hospitals, DHS, the Maryland Department of Health, you guys need to find a solution. We need to do better. Everyone for years have been kicking this problem to someone else. Shame on us. Shame on us. Because this deserves attention and care. And yes, it costs money, but we need to find that money because it should be a priority. They're children, for goodness sake. They're the future, and we're shaping them. We're causing a lot of trauma to them. This committee knows that we have been working really hard at reducing the emergency department wait time, right? We passed legislation last year. What do you think this does to the emergency department wait time? What does it do to your constituents that are waiting for a bed that cannot have that bed because a child has that bed? Right? We need to do better. It's really shameful. This bill will not fix everything overnight, but it will immediately take steps to expand capacity, to increase accountability, because these are the most vulnerable kids, people that we have in our society, and for these children to get the care they need. The bill does 4 critical things. First, it expands residential treatment capacity by directing the Maryland Department of Health to staff the 17 currently unstaffed state-operated residential treatment beds. Should I say that again? Unstaffed. We have some beds. These beds exist, but they remain unused, while children languish in hospitals. The Maryland Department of Health can use already designated funds for the adolescent hospital overstay program to make this happen. It requires state hospitals to participate in the Maryland Mental Health and Substance Use Disorder Registry. That's the bill that this committee passed, that we have been working on it for at least 5 years. Unlike private hospitals, the state currently lacks real-time visibility of its own availability when it comes to beds. And those of you that know me, I told you the story that I went with a constituent to a hospital. I gave his family a ride because they didn't have a car. And I'm not saying this for you to say, oh, I did this. No. Okay? Because a lot of times it is best not to say what you do, right? But I got there at 10 o'clock at night, and I was still there with that kid 5 o'clock the next morning. And this is a child that wanted to commit suicide. When I came out of there, I was in tears. I was so upset. I did not say I'm a delegate. I didn't make any calls because I wanted to see how long it took this kid. And it took weeks. This is a real problem. It also establishes the Pediatric Hospital Overstay Coordinator within the government's Office for Children. Someone has to be responsible. Someone has to manage these kids. Someone has to manage these cases. We can't just say, we'll take care of it. Someone will take care of it. No, who is the person that has to do it? And we need to hold them accountable as well. These children are worth it. The coordinator will also report annually to the governor and to the General Assembly. And they will give us the status of these kids. It will direct this bill, the Maryland Department of Health, to review and reform reimbursement rates for residential treatment centers, because that is important. This crisis didn't appear overnight, and we're not going to solve it overnight, but we cannot afford to wait. We cannot adjourn on April 7th and not take care of these children, because no one's caring. As of February 14th, there were approximately 59 children across Maryland that were stuck in hospitals, with nearly 29% of them in the emergency room. Approximately 73% of these youth are between the ages of 6 to 17. 6. 39% of them are involved with the Department of Human Services, local services agencies. And what I heard from some of the nurses is that sometimes they don't even have clothes. They don't even have their books to stay on top of their homework. They're supposed to get their assignments, right? They're supposed to get classes while they're there. And approximately 63% are waiting to be placed in residential treatment centers, foster homes, or group homes. So the Department of Health need to find money to get the workforce that is needed for these residential treatment centers. The Department of Human Services needs to think about how to expand the group home and foster homes. The hospitals need to also have a dedicated person that will start working with the community to see what services are out there. Do you see the connection here? It takes all of you, all of us. And we need to make sure that we have more community services for these kids before we place them in the most restricted environment. Because the law says that we must place them in the least restricted environment. I'm not pointing fingers at anyone. I'm pointing fingers at all of us. because we are failing these children. And I know the fiscal note is high, and it says something like $4 million, but I want to let this committee know the following. In state fiscal year 2023, DHS spent a total of $3,308,000 to place children in out-of-state residential treatment facilities. Out of state. In fiscal year 2024, they spent $4,816,000 to place children out of state. The average per diem rate in fiscal year 2025 for out-of-state RTC and nursing care for providers is $1,128.56. The average cost for in-state RTC providers is $672.30. What is wrong here? What is wrong? We will save money, but forget saving the money. We will treat kids in a humane way, with empathy, with love and care. This needs to be figured out before April 7th. Otherwise, you're gonna see it in the paper and something is gonna happen. And I'm not even touching, because this bill doesn't deal with the kids that are at the hotels, that are unsupervised. Again, shame on us if we cannot figure it out. I hope this committee does something about this. And I want to thank the Appropriations Committee for working with us on this as well. Thank you. Who would like to get started?
Madam Chair, thank you so much. I'll jump in. Just for the record, Andrew Nicholas, still with the Maryland Hospital Association. Look, I've got some remarks here. You can see them, but I think I'm going to pivot and say me too to that incredibly passionate and comprehensive testimony on this issue. And I'm just going to thank the chair so much for her engagement, sponsorship of this bill, and engagement on this issue. The Hospital Association is ready and at the table and will continue to be to drive a resolution to this issue. We've got a panel here of experts, of providers that are going to offer different, perspective on this issue from different lenses. So I'll defer to them, but just thank Delegate Woods, Delegate Bagnall, Delegate Shetty, the Vice Chair, and of course you, Madam Chair, for all of your engagement and helping to do this. It's a challenging issue. And it is about the kids. That's the bottom line, is making sure they're getting the care they need. And so hopefully we can drive to a resolution. We're all in on that. So I'll defer to my panel at this time.
Thank you. Who will be next, please?
Do you want to go or should we start? Sure.
And if you, as you speak, will you be so kind and put the microphone close to you, okay?
That's a good idea. Thank you. Good afternoon, Madam Chair, and may I also thank you for your impassionate statement. It was quite refreshing. My name is David Stockwell. I'm the Chief Medical Officer of Johns Hopkins Children's Center, and I'm here to express Johns Hopkins' strong support of HB 962. You will hear from the other members of our panel about different impacts of these pediatric hospital overstays. What I want to highlight is an impact on other children. Unfortunately, we do share that same experience that you'll hear about later, and ensuring that our patients are in the best placement for healing and the development is our top priority for this legislation. In 2024, we had 1,591 days of boarding, of which 65% were children awaiting DSS placement, the children you're speaking of. This took 3 to 5 beds of ours offline for use by medical, surgical, and psychiatric patients for the entire year, which led to 218 admission denials because we are always at full capacity. Of these, 39 required ICU level cares, the denials, and were urgently transported to facilities out of state, an additional cost. JHCC is the only level 1 pediatric trauma center in Maryland and the only ECMO center in Maryland, which is the highest level of care. Any denial to our facility could place a child in imminent danger and certainly delays treatment. From a staff perspective, our social workers spend an average of 6 hours per child per week on care coordination. Each child typically has one-to-one staff supervision, a separate security detail, and high levels of nursing engagement. All tremendously valuable hospital resources, and they deserve it. Lastly, some of these children have destroyed medical rooms, taking them offline for weeks after they leave. Our top priority is the safety and the well-being of children, but these hospital operational issues are important. As I know, the committee deals with legislation on ED wait times, workplace violence, and healthcare workforce shortage, all of which would be helped by passing this legislation. We have failed these children. It is the legislature's opportunity to create some accountability and investment in helping them. For these reasons, I urge a favorable report on HB 962.
Thank you. Next, please.
All right, Chair Pena-Melnick, thank you so much for your words earlier, and members of the committee. Thank you for your opportunity to provide testimony in favor of House Bill 962. My name is Dr. Jennifer Dorr, and I'm a child and adolescent psychiatrist at Children's National Hospital. Today, I'm speaking on behalf of Children's National, where approximately 60% of our patients are Maryland residents, as well as the Maryland Psychiatric Society and the Washington Psychiatric Society, all in very strong support of this bill. House Bill 962 aims to have pediatric patients admitted to the least restrictive environment appropriate for their clinical needs. This bill has a strong aim and is very important to the quality of life of our pediatric patients. Being on the front lines, I see what a devastation can be caused if a child is unable to be discharged from inpatient care when they're stabilized. While working on the inpatient unit, I encountered a 14-year-old patient who had PTSD from significant abuse as a younger child and a genetic syndrome. He was stabilized after a few weeks inpatient. However, he remained on the psychiatric unit for over 5 months awaiting placement. This not only took a bed from someone else and was a huge cost to the system, but this also greatly affected his overall mental health. When a child is stabilized in the hospital but has to stay for months, it's a serious issue and may halt social, educational, and developmental growth and can worsen their mental health. They may feel trapped because essentially they are trapped. A hospital or an inpatient unit is not an appropriate place for a child to grow up. We need to do better for the children of our nation and especially our state. I have several other examples, and quite frankly, we're failing our children. Please help us as child and adolescent psychiatrists help our patients and families. Let's stop punishing our children and families who come to the hospital for help. Let's not continue to give them significant emotional and financial trauma. Let's do better for our children. Thank you again for the opportunity to testify, and I ask for a favorable request for a report on this bill. Thank you.
And thank you. Go ahead.
Madam Chair, Vice Chair Cullison, and members of the House HGO Committee, thank you for the opportunity to testify on this critical bill. I also thank the Chair for recognizing its importance. My name is Carrie Etheridge, and I'm the Director of Social Work at Sheppard Pratt. I'm here to share my firsthand experience in hospital, inpatient psychiatric, and residential treatment center processes to highlight the challenges our pediatric patients and care providers face daily. Extended hospital stays without appropriate therapeutic care exacerbate anxiety, depression, and behavioral deterioration. Children miss critical education and social development opportunities when confined to a hospital setting. Being hospitalized for extended periods of time can be re-traumatizing, leading to worsening mental health conditions. And many children decompensate in hospital environments, leading to escalated behaviors requiring more intensive interventions. Overstay patients occupy beds that could serve other children in psychiatric crisis. Our hospitals must hold children in emergency rooms while inpatient beds remain full, delaying care for new admissions. Extended stays require hospital staff to provide long-term care without the specialized resources needed for rehabilitation. Hospitals must allocate resources for non-acute care rather than crisis stabilization, impacting overall efficiency. Sheppard Pratt fully supports efforts to address pediatric hospital overstay challenges and enhance care coordination. Ensuring a robust continuum of care benefits not just overstay patients, but the entire behavioral health system. For these reasons, Sheppard Pratt urges a favorable report on HB 962. Thank you.
Good afternoon.
Good afternoon, Madam Chair, Vice Chair, and committee members. My name is Maria Manna. I'm a registered nurse and the Director of Care Management at Northwest Hospital. I'm here today in support of House Bill 962. Northwest Hospital has 2 to 4 adolescents, ages 13 to 17, in general, stranded in the ED on any given day. While those numbers in and of themselves may not appear staggering, the associated length of stay of those patients is usually 2 weeks to 90 days. We recently discharged a patient held in the ED for 90 days after searching unsuccessfully for an inpatient acute psych bed. We currently have 2 adolescents with 30 and 45-day length of stay in the ED awaiting community placement due to abandonment. Northwest ED adolescents fall into 2 groups: adolescents that require an inpatient acute psych bed and adolescents who are abandoned by frustrated and desperate parents or group home providers. In all situations, the hospital ED is by default home. The ED is lacking in structure, cannot provide ongoing treatment, and creates unnecessary exposure to risk. The hospital is challenged to find psychiatric beds for our adolescent patients. Locating a bed is a painfully antiquated process. The lack of available beds and high demand creates low yield. Adolescents abandoned in the ED poses yet an additional dilemma. Hospitals must partner with multiple agencies such as 211, local care teams, DSS, DDA, BHA, CPS, and the hospital youth liaison to find placement. Lack of agreement among agencies as to who is on point is common. There is a lack of urgency and accountability by the agency as they perceive the patient is in a safe place. Foster homes, group homes, and residential beds are sparse. Accessing those beds due to linear, inefficient, and convoluted processes is the norm. In summation, the lack of a singularly focused, coordinated, systematic approach with an accountable owner delays expedient discharge to an appropriate setting and adds to the ED throughput burden. Thank you.
Thank you. And we have one more witness virtually, and then I'll open it up for questions. And we do have the Department of DHS and MDH will be next, the next panel, just to let you know. Can you please bring the Megan Perman? Good afternoon. Will you be so kind and unmute yourself and give us your testimony, please?
Hi, good afternoon, Madam Chair, Vice Chair. Oh, I'm sorry, can you hear me?
Yes, we can.
Thank you.
Thank you for being with us.
Thank you for having me. I want to especially thank you, Madam Chair, for sponsoring this important bill on the behalf of kids that we at this witness table are privileged to care for and desperately need a champion outside of our hospital walls. My name is Megan Perlman, and I'm the manager of social work here at the University of Maryland Medical Center. I have been a licensed social worker for 14 years. Most of my work focuses on children and youth. In recent years, we've seen a troubling rise in the number of children remaining in hospitals without medical need. Since May 2024, I've worked with 23 pediatric patients who've experienced a total of 512 medically unnecessary hospital days. One child, for example, stayed in the hospital for 172 days beyond medical necessity. That's nearly 5 months occupying a hospital bed during the summertime. This youth spent her entire summer in the hospital. This is not only a strain on medical resources, but also disrupts hospital operations, most importantly, denies children the stability and care they deserve. Many assume hospitals are places of rest and recovery, but the reality is far different. Most of these days are filled with sounds of beeping equipment. Families can be heard grieving in the hallways, all while youth who are medically ready have no reason to be in the hospital are sitting in hospital beds, waiting to know when and where they're going to leave. This is not a place for medically ready children who should be in school with their peers, experiencing milestones that of their peers. While I understand the work of DHS is challenging, the lives of these children are even more so, and collaboration with our hospital teams is essential to finding an appropriate placement for these children. And in conclusion, I strongly support House Bill 962, which will provide critical tools to ensure that our vulnerable children and youth are placed in proper settings.
Thank you. I know we had Catherine Whitaker, but she's not there. So we're going to open it up for questions. Chair Chetty.
Thank you.
You're welcome.
Thank you, Madam Chair, for your leadership, long-time leadership on this issue. This is a complicated one, and I'm always in awe of your ability to bring stakeholders together who need to be at the table. And this is just one of the most complex challenges that our state is facing and the most worthy. So I am really, really grateful for the opportunity to sit here today. I want to just sort of be careful in how I word these questions because while they may not entirely be appropriate for this panel, and they may be more appropriate for DHS and MDH, I do think the hospitals might have some ability to weigh in and share their perspective on whether, based on the patient population that you're seeing in your hospitals, whether you can provide some insight here. So in our appropriations subcommittee, we just today wrapped up our hearing on the Behavioral Health Administration within MDH, and I don't even know what day and time it is right now, so forgive me, maybe like a week or two ago, we did the Department of Human Services social service budget, and because this work crosses multiple agencies, I'm going to reference a couple of things here as I note this. So in your testimony, you all have shared a bit about the unique population that predominantly you're seeing, some of which are within our foster care system already. And we do have something like 7 different license options for placement settings within the foster care system. And some of them are for, children who have behavioral health needs or mental health needs. And I don't know that we necessarily have a license level for, or reimbursement level for care homes that do both. So I'm wondering if you can comment a little bit on the patient population that your facilities are seeing and, what the current barrier is in terms of placement for those that are within our foster care system specifically. And then related, I'm going to flag just from our Behavioral Health Administration budget, in the event that I'm not here to speak again when the second panel comes. There was $2 million in BHA for hospital discharge, RRP, residential rehabilitation programs for community expansions, for 35 new RRP beds, 7 beds that have been budgeted for opening at Brook Lane, specifically for this population, I understand. Over $1 million for adolescent inpatient substance use disorder treatment for 15 beds in Montgomery County. An additional $10.3 million for the 1915I waiver expansion for home and community-based services. So I'm wondering if that expansion from 200 to 1,800 slots could potentially support this as well. And again, I recognize that this is not necessarily appropriate for this panel, but based on the population that you're seeing in your facilities, whether you can speak to whether any of these funding mechanisms we have in place right now budgeted for FY26 could potentially support these efforts, or whether we need to be thinking more, in addition to what the chair's bill recommends. Thank you. Sorry, it's a long one.
So if you don't mind, if we could break that up into 2 responses, I'll speak to the funding piece, and then to the piece as far as what's the hurdles, I'd like our experts to address, if that's okay, Madam Chair. So just quickly on the funding piece, first I'll say we're working on that with our counterparts in the departments, but specifically for the Brook Lane funding, so Brook Lane has a program right now where they are able to take some of these kids who are awaiting placement
and hold them. It's still not a permanent placement, but it's at least not in a hospital. And so there was a request in, and I think there might be some misunderstanding about what the funding request is. It is to continue the current program. It is not to expand. That funding is needed for the current program that they're running, which is valuable, but of course, the current program exists and we're still in this situation. We hope, this is I think as far as we can go at this time, that those other funds you've identified could be directed towards opening up capacity in the state to address this issue. As I said, we have had meetings with the departments, and well, I won't speak for them. They'll be able to speak to some of that, and so I'm not sure that they feel that is feasible for all of those options, but that is our hope, and we're still trying to dig into some of that. And then,
I think I can speak to the Brooklyn piece. I think we were all excited when that happened. And I think, to your point, we utilized them several times, but now there are 7 stuck kids at Brooklyn, right? So we need more. I don't know if we need more of Brooklyn, perhaps, yes, that would help. But the community, there's an issue with community throughput. There's an issue with finding places after. So it was a nice step down. But now we can't refer any more kids to Brooklyn because the kids that were referred to Brooklyn are now stuck at Brooklyn, probably in a similar time frame that our kids are. So there's that. As far as, the types of kids that we see, the reasons given to us by DHS and others are anything from there aren't beds available to there aren't staff at these group homes or other places, and or there are no foster families, parents willing to take a child with this level of whatever it is, disruptive behavior, psychiatric diagnosis. Those tend to be what's told to us as the reasons. And, a lack of wraparound services in our community in general, it doesn't exist. And what is there is not enough. So I don't know if that answers all, but yeah.
Hi, I would echo the concerns around Brooklyn. We've actually been able to place one patient from our ED into that Brooklyn high-intensity unit, and that was just a transition phase for the patient to get to a residential bed when it was available. As far as the community resources, that whole process and working with the various agencies to try to determine what the first step is to take to get that patient to an appropriate community setting, I can't even begin to describe the frustration there. I often become the person pushing that envelope on behalf of the child and that parent who is desperate to find the appropriate services for that child. At one point, when a parent was so desperate that they abandoned their child in our ER, we called CPS, and CPS would get involved, be on point. That does not happen. At this point, the hospitals have to engage the local care teams. They then have to engage care coordination. Care coordination at the most, at the highest level, it supplies 15 hours of service a month in the home. That is not enough to sustain these families, et cetera. The availability of foster homes, as previously mentioned, group homes. There may be 15, and you go through the list and it's a denial one after the other because the staff know the patients because they make the rounds at the various group homes, and so then they're denied because they don't feel that they can manage the patient's needs. Foster homes, again, there aren't enough. And at the same time, that patient sits in our ED, not able to get what they need. It's a cold environment as much as we try to show caring to those children and give them what they need. It's a sad substitute.
I saw Delegate Riley first, followed by Delegate Kaiser, then Rosenberg.
Chair, this is definitely a huge problem. Have spoken to many physicians and many hospitals, and it's happening throughout the entire state, not just one hospital, but all over. And it is a challenge, and I really appreciated Delegate Shetty's, she was very, very delicate in her questions, and the answers were great. I appreciate that. So in hearing what you're saying and listening to the entire panel, and then from what I've heard from our hospitals, as we visit them, that probably 90% of these children that are coming through the ED time, okay, first of all, most of them are foster kids. Most of them, the parents are not, or the foster parents are not picking them up. And it sounds like for the reason and for the purpose that they're not being placed in these community centers or other foster homes is because of their behavior or, their mental capacity or, suicidal, whatever. But it's all falls under the behavioral health scenario. So do you think for the majority of these children that it would be best if we had a facility more so for children that deal specifically with behavioral health, or place them in another community home if they were available? What do you think would be best served for these patients or these children?
So I'll speak to that in sort of a roundabout way. So I think as a child and adolescent psychiatrist, we're the ones making the decision of what level of care we're going to have a patient be discharged to. So if I feel it's appropriate for a child to go to a foster home, that's the least restrictive level outpatient care, of course, that's what I want to do. However, a lot of times, I'm not saying all the time, and I don't know the specific numbers, these children are awaiting residential placement not because we can't find a foster placement, because what's available does not impact their medical needs. So I make my recommendation based on what I see. So a lot of times these are children who have attempted suicide several times, have been to inpatient facilities several times, and they've failed lower levels of care like outpatient, like day programs. So by the time we're recommending a residential placement, it really is that patient cannot be safe anywhere except a residential placement. So I think yes, both areas of need are very true, and we need more community resources, perhaps even to prevent from getting to that point of needing residential placement. But right now, we desperately need residential placement as well.
Okay. Thank you very much. I appreciate it. Excellent.
Delegate Riley. I have next Delegate Kaiser, followed by Rosenberg, then Hill, and then Taveras.
Thank you, Madam Chair, and thank you for this great bill. And I know that Delegate Rosenberg had a bill last year that was dealing with this overstay issue, which is when I became somewhat familiar with it. I just want to clarify for everyone else. I mean, I think everyone's hearing the story and thinking how sad it is that a child is in an emergency room for any extended period of time, getting no services in terms of not getting any of the mental health supports they need, not needing to be there, all the trauma of being there, no education and all the rest. But I don't think people realize if a kid is in the emergency room for 3 months, taking one bed, they're not just, that's not just one bed. That's what, 3 or 4 people that could have used that same bed in a given day? I mean, I certainly know when my, and so that's what I want to clarify. I certainly know that when my mother or aunt was in the emergency room, they might have actually been there for a full 24 hours, but only 24 hours. I know that when I sprained my ankle and had to go to the hospital, I was only there for about 4 hours. I got taken care of right away. Advice for everyone, go to the hospital at 5 a.m. But I guess I would just like the estimate to just make it clear for everyone. A hospital bed for 3 months is actually taking away, what, maybe 4 times 90 days? Basically taking 360 hospital beds away in an emergency room. Is that a decent estimate?
I would think so.
Yeah, if not more.
If not more. Thank you.
Can I just add that these children will occupy an emergency room bed. We have had so many, I think my colleagues have had similar experiences. We had to, in order to see children that need emergency care, we've had to move them to acute care. That's what I was trying to focus on. So they're upstairs. They're in a medical bed or a surgical bed. We are constantly full. And so when we get a phone call from another hospital in the area that has a child that needs medical care or surgical care, acute surgical care, we often can't take them because we do not have a space to put them. And when I was mentioning earlier about an ICU child, there are times when our ICU is full And we may be able to move a child out that's ready to go to acute care, downgrade in their care. They're getting better. But we can't do that because there's nowhere to put those children. And we have to deny a critically ill children a bed and treatment in the state of Maryland who is from the state of Maryland, and they go outside of the state to get their care. It breaks my heart. So there are more victims than just the children that we're talking about that are in foster care. There are many, many, many other children in the state of Maryland that are impacted here.
Go ahead.
Flashing. I heard you say foster care, but if I understand correctly, and I may have heard you say it too, Madam Chair, but in some cases, the parents brought them to the hospital and have walked away. So we're not just talking about foster kids.
Correct.
Is that correct? Okay.
That is correct.
Thank you.
Thank you for the clarification.
Yeah, they'll abandon them. Yeah. So I have Rosenberg, followed by Hill, followed by Taveras.
Is there a broadly speaking demographic of the children who are left at the hospital that you can speak to in broad terms?
So I would say in the data that we're collecting right now, I'm not sure we have that level, but we can look to refine that. We certainly know the ages. We know the broadly, we can get information on kind of what brought them in and the care they need going out. But I'm not sure we have the demographic.
Thank you.
And if I may add to that, we were going to have a person from UPMC Western Maryland to give the rural perspective because it's also a problem in the rural area. It's everywhere. I have Delegate Hill, followed by Taveras.
Thank you, Madam Chair. Thank you for this bill, and thank you, panelists, for your work. I guess I'm trying to get to what you guys see as potential low-hanging fruit, right? So I know that when I talk to young people who are finishing college, there are a lot of them who have undergraduate degrees in counseling. There are about 80 graduate or master degrees in counseling that we're doing every year, but many of them can't find jobs. So that's the first part. Are we taking the folks who are coming out of college, graduate school, and getting them plugged in? Are we partnering adequately with academic institutions to do apprenticeships or externships or programs to increase that line? And then the second question really has to do with, in 2017, Good Shepherd was one of the residential treatment programs. It closed. And to my knowledge, nothing ever opened up to replace it. So those beds were lost. I'd like to know why it is that when we close places, we don't replace them. So those are the two questions.
Answer that.
I could certainly speak to the second part of the question. The simple answer is the rates for residential treatment centers are very low and very difficult to sustain those services. And they're actually even done in a very challenging way where it's a reimbursement after the fact, which just adds to the challenges in doing those centers. Now, interestingly, very similar levels of care, but classified differently, were just done a rate evaluation by the Department of Human Services. And what we have heard from providers is that's actually working very well. And part of the bill encourages a similar look at a similar study for residential treatment centers, rate, how their rates are structured. Because we would love to see that. What we've heard from providers is essentially what you have is the beds classified residential treatment that would serve these kids. You know, they have a unit that's the same thing, but classified a little bit differently, providing essentially the same level of care. You wouldn't be able to tell the differences if you walked through them, but operating much more sustainably. And so we'd like to see that done as well. Again, you know, there's fiscal implications to all of this, and I'm sensitive to that, but we think that that's an important concept. Okay. And remind me your first part of your question.
Well, the first part was about, are we working with academic institutions to create programs to put more counselors and other folks along the health care provider spectrum into the workforce. We've certainly done it with nursing, where some hospitals have partnered with community college to make sure they're coming through. I know there are a lot of kids who are young people who are coming out with counselor degrees and can't find jobs.
I can speak at least to the social work piece. We're not struggling to hire social workers at Shepherd Pratt right now. I think if you're speaking of a pipeline in order to get some of these RTCs funded, such as RICA, I think they're talking more of frontline staff, to be honest with you, and talking about those types of entry-level workers that they're having trouble hiring. Same thing with the group homes, but I'm not seeing such a huge disparity when it comes to at least social work applicants. We have a pretty robust intern system. And
so the bed problem is not staffing from where you see it from a social work
I
standpoint?
don't think from a clinical standpoint. I think it's more from frontline staff, yeah.
Okay.
Yeah.
Thank you.
I think the Megan had her hand up.
Go ahead, Megan.
Thank you. Yes, I too echo what was just said about the staffing.
Hold on one second.
Megan, can you hear me?
Oh, yes, I can hear you. Can you hear me?
Yes.
Oh,
Can you please address the question? Okay?
Yes, I agree with what was just said about social work staffing not being much of the issue. We have a lot of applicants. We also have a fellowship opportunity that allows folks to apply and receive a job offer before they're licensed, and they have about 6 months to get licensed in that job opportunity. What I am seeing here is really streamlining the ability to access those resources. And again, not so much that staffing is the challenge.
Can you elaborate on that a little bit, please?
With regards to accessing the resources. So it seems very difficult to understand why referrals are made to only specific care partners or levels of care in the community. We have struggled to partner with our DSS partners to help and support them in making these referrals. So there are providers out there that we're aware of that we find out are not, they're not being looked at as an opportunity for that child to receive care from. And so I think with this House bill that is highlighting the opportunity to streamline or provide some more care coordinated services would really, I hope, be a part of a solution to this issue. Again, I don't really see it being as a staffing challenge.
A clinical staffing issue.
Yeah, I don't see it being a clinical staff.
May I ask one follow-up, Madam Chair?
Yes.
Thank you. So some years ago, some psychiatric social workers that I knew said that one of the problems getting folks out of the ER, young people particularly, is that they would have to have 3 denials before they were allowed to be admitted to certain kinds of programs. I see some nodding. Can someone explain what that's about and if we fix that or if that's still an issue?
I think part of the problem is that we get different answers from different people from different counties. We get different answers from different people, from different counties, from different agencies, to be frank. And there's a very, I don't want to say secretive because I don't know that it's intentional, but there's a thick wall, and you're reliant upon whatever that DSS worker for that particular child is telling you. There's no transparency. You're not sure how many places they've looked into, who said no, why they're looking, to Megan's point. It's all handled outside of your control. And every once in a while, you'll get someone who works with you that will give you a spreadsheet. That has been very rare for me. That says, we've looked at these 5 placements, all 5 placements that said no because of aggression, because of history. But the entire process is handled outside of any hospital's control of information. And so we are really reliant upon if they want to tell us when they want to tell us, and how often.
And then after 3, they are allowed to go in a state facility? Is that what it is? After 3 denials, they then qualify for?
No,
different-
it's really, I mean, it's really based on the doctor's recommendation. The doctor, the physician is really the only one who can recommend a level of care. It's not based on availability, it's based on what the child needs.
And Delaware and the other out-of-state places that will take these kids, they have what? Better clinical support? They have better, other than better
Availability.
reimbursement?
They have availability. The 3, I've not heard 3 denials. What I have been told in the situations where you do have a recommendation for residential treatment and you have a completed and approved certificate of need, because the con has to be done by a psychiatrist for residential, then you can pose the referrals to all of the in-state residential treatment centers. And once all of those deny, then you can refer out of state.
That's a lot of time. Thank you. Thank you, Madam Chair.
Let me just follow up quickly. Ms. Perriman, can we peel the onion a little bit? Let's go back to those providers that are not being referred to. I want you to tell me a little more about that.
Yeah, so there are times where I'm getting inconsistent information about where referrals are made or where they were not made. And so the list of licensed providers is available online. So some of my social workers have gotten creative, and we will call those providers and ask if a referral was made. Sometimes we hear no, or we don't know what you're talking about, or we'll hear, oh yeah, that was made a few months ago and we denied them. So it kind of leaves open the opportunity to re-refer and speak to the gains that were made in the time that they were here with us. So, and I think some of what you just heard kind of also highlights the difficulties in understanding where the referrals were made, why they're choosing some of these places over others. You know, we very clearly give the recommended level of care, and we hope that they're making those referrals to that recommended level of care accordingly. But again, it's not always clear where they're making these referrals, and so when we call behind them, we're finding out that some of them have been made, some of them were made, you know, maybe like historically, some of them were denied because there wasn't a bed at that moment in time. I hope that answers the question.
The list that you have, is this a list kept by who?
This is a list kept by I want to say it's the licensing board. I'm sorry, I can't recall off the top of my head, but the licensing body for the group homes or the agencies that provide foster care services. I can send it to you certainly, and make sure it's online. It seems to be updated regularly.
If you can send us that link, that will be great.
Yeah, absolutely.
And I really appreciate all of you being candid, because we need to peel this onion, right, to understand it. Delegate Taveras, thank you so much. Delegate Taveras.
Thank you, Madam Chair. One of the big, I do. Okay, sorry. One of the things that I would like us to consider are in this type of conversation is that we may have parents that maybe lack capacity, right, to deal, and foster families as well. So can we look at places like the Chelsea School that provide, let's say, sit down, have one-on-one services with with these children, and residential programs like Boys Home, where it's like 5 students to a classroom, not 30 or 40. I think that those are out of state, because I don't think we have, outside of like maybe the Seed School, which is a little bit too big. I don't think we have those types of services here, but there are some other schools that cater to smaller classrooms. And maybe something like that may fit these types of students.
Delegate, I think we need all of these, more of all of these things. I will say that I think, one of the things, wraparound services for families is absolutely critical. That's how you avoid, having these kids come into the hospital in the first place. Many of these, incidences could likely be avoided if the family had access to those services at home. So that's got to be a parallel conversation. How do we increase access to those services? Because parents are making this horrible choice to abandon their kids because they simply cannot provide for them. And sometimes it actually enables them to access services that they can't otherwise afford. And that's terrible. And so absolutely building our capacity for wraparound services. I do know the department is performing the 1915I waiver, which I believe does have an element of that. Again, the department will be up and they can speak to that. And then certainly other schools. I know there are some, like the Laurie Center that operates in Montgomery County, serves vulnerable children. It provides amazing services, but they, like other programs, have incredibly long wait lines, and we just need more of them.
Well, the Chelsea School is in my district, but I'll just say they're excellent. Yeah. My concern is that if there is a failure, let's say in the public school, where I've had situations where I've had to deal in those households, and the parents are simply terrified of their own children. That's why they're leaving them in the hospital. But by the time that happens, there's been a lot of failure along the way. But if we could get to the root cause of that earlier, I think it would be better. And I feel like places like this are the solution. But thank you.
Okay, so I don't see any other questions. I know this is taking time, but this is so important, and these kids deserve it, okay? I am going to thank you for being here. I know you took off work, all of you, and thank you for your passion and your commitment, okay? I am going to call next.
Thank you, Madam Chair.
You're welcome. I'm going to call next, Megan, thank you, the Department of Health, and I want to also call the Department of Human Services next, please. So who would like to get started?
Sure. Good afternoon, Chair Pena-Melnick, Vice Chair Cullison, members of the Health and Government Operations and Appropriations Committees. My name is Webster Yee, and I serve as the Chief of Staff for the Department of Human Services. We support House Bill 962 with 2 consensus amendments to help clarify the bill and improve implementation and coordination with the Maryland Department of Health and our hospital partners. One amendment changes the age from 22 to 21 and raises the time from 24 to 48 hours to the definition of pediatric hospital overstay patient. The second amendment clarifies the coordination with the Department of Health regarding transfer of youth in the care and custody of the Department of Human Services. We agree with the intent of this bill and thank the Chair and Delegates Bagnall, Woods, and Shetty for their leadership on this subject. To be clear, we agree that a hospital overstay is not acceptable for any child, yours, mine, or those in the care of the state of Maryland, and we will continue to work on addressing this challenge. I know you often hear that we are not proactive in our work to reduce the number of youth in hospital overstays, but we are meeting with agencies and hospitals weekly and have taken steps to limit the number of youth who experience hospital overstays in this administration by addressing the systemic gaps and increasing communication and collaboration. In the last 18 months, we have accomplished the work that has been neglected for 10 years, and we have seen improvement. In 2024, we have developed new kinship care resources, issued new out-of-home licensing regulations, implemented a modern rate structure for our residential care providers, and hired a full-time hospital coordinator to see our children receive appropriate placements after medical discharge. As I've stated, no child should be in an overstay, and we're making progress towards that end. As of Monday, February the 24th, we have 12 DHS youth in hospital overstay. A year ago, we had 21 youth in hospitals. On February 7th, we issued a new policy directing our local offices to quickly identify the most appropriate and least restrictive setting, ensuring that no DHS youth remains in hospital overstay. And to Ms. Perlman's point, this policy is statewide and will standardize coordination across all of our local offices. This policy, in addition, requires weekly visits with a youth in a hospital's overstay by our local staff and clearly outlines educational and well-being expectations. In 2025, we will continue our work to improve hospital care coordination, rate reform as proposed in the governor's fiscal year 26 budget, and to continue our Family Matters work, to Delegate Taveras' point, so that our youth stay with their kin or blood families. In addition, we will issue a new statement of need this spring, urging Maryland's providers, as well as out-of-state providers, to express their interest in providing programming to serve youth with complex medical and behavioral health needs, including diagnostic evaluation and treatment programs, psychiatric respite programming, emotional, cognitive, and developmentally delayed individuals, females, and commercially sexually exploited youth. Thank you for your time. We urge a favorable report with our amendments. Happy to take questions at the end of this panel.
Please.
Thank you. Good afternoon, Madam Chair, Madam Vice Chair, and committee members. My name is Tanya Schwartz, and I serve as the Director of Urgent and Acute Care at the Maryland Department of Health Behavioral Health Administration. The Maryland Department of Health thanks the committee for the opportunity to provide support with amendments for House Bill 962. The department fully supports the intent of this bill to ensure that youth with complex behavioral health needs receive clinically appropriate care to support their health and well-being. This afternoon at the Behavioral Health Administration's budget hearing that was alluded to earlier, funding, the hearing, Deputy Secretary Lord highlighted funding this. Deputy Secretary Lord highlighted funding this and other key legislation in response to DLS proposed budget cuts. I think we can see today, and I appreciate your leadership, Madam Chair, that there's a collective understanding that this is a critical issue that needs to be addressed across our state. And over the last 2 years, we have been working closely with key partners to identify solutions and leverage additional assets to support this endeavor. Today, we would like to propose amendments to HB 962 in several areas that we believe will enhance the legislation and the state's ability to address hospital overstays. I will address some of these here, and others are in our written testimony. First, based on 1121 of 2020, the department is procuring a software vendor to establish a statewide bed registry and referral system. The department proposes an amendment to require hospitals and all inpatient, outpatient, and crisis behavioral health providers to provide information and update their service availability in real time. Second, we recommend, as DHS alluded to, defining a hospital overstay as a stay that exceeds 48 hours in the emergency department, which aligns with the time frame in COMAR 102131. The department proposes an amendment that if a patient exceeds 48 hours in the emergency department and the hospital or bed registry, thank you, Madam Chair, and the hospital or bed registry shows availability for an inpatient bed, the hospital will seek the appropriate transfer to maintain the clinical stability of the youth. Third, the department proposes, Third, the bill proposes that the department, in coordination with the Department of Human Services, ensure that a pediatric hospital overstay patient is transferred and treated in the least restrictive setting possible. The department proposes an amendment that the setting should be based on a clinical determination. The department would also like to clarify that it is not a placement agency, nor does it have the authority to ensure admittance to a facility or program. The department has no legal authority for the transfer and treatment of youth. Thank you for the opportunity. I know I'm already over time, so we appreciate the opportunity to provide testimony on this critical initiative, and we are eager to work with you and all of our partners to continue to address this issue and to really build a full continuum of care, a full continuum of behavioral health care for our youth. Thank you.
Thank you, and I want to thank both of you for coming. I know it's not easy to sit there, but I thought it was important, right? For you to come. And thank you for being at the table because we have to solve this before April 7th. I have some questions, but I usually wait to the end. I'm going to start with our guest, the Appropriations Committee, to see if there are any questions. Okay, so let's open it up for the committee now. We have Delegate Hill.
I think this question is for you, Mr. Yee. First of all, it's good to see you again, Lester, in your new role. So with nursing homes, when they have residents who are admitted to the emergency room, whether it's bedsore or UTI or whatever, they're required to keep that bed open for a certain number of days. It might be 48 hours or 72 hours, so that when that patient is ready to be discharged, they can go right back. I don't think we do that for residential treatment places, and so we have some cases where they're sent out from someplace, and then when they try and place them back, they're denied readmission. Would a similar policy be contraindicated? I'm sure that if they consider the kid a behavioral problem, they might not want them back, but if they're certified, they should still be more qualified and appropriate than the emergency room for the kid with those issues to be sitting.
Delegate Hill, I think I'm going to have to defer to my colleague from the Maryland Department of Health. Off the top of my head, I don't believe that there is that type of requirement.
I can take your question for the record and get back to you.
Okay, thank you.
Delegate Woods.
I just wanted to get some, thank you, Madam Chair, some clarification, I believe, in response to Delegate Hill's question that, and please correct me if I'm wrong, I know that at one point there was an establishment that if that child was gone more than 72 hours, then the facility could deny them returning. Is that still the case?
Delegate Woods, I think the answer there is very complicated. With respect, it depends on the level of care. You've got residential treatment centers, you've got private foster care, you've got group homes, and everything in between.
Right.
And so I don't want to guess, and again, to my colleague's point, we'll check and get back to you on that part.
All right. Thank you, Madam Chair. I know that's the case.
So I have to get up because I have a meeting with a new secretary and I have counsel already. I need to keep it, but I'll be back. We're almost done. But I do want to make the following request. And I know the governor's office, June Chung is here. Okay. Look, I know we find money when we want to. This is a priority. So I need you to look at the amount of money that DHS is spending every year, millions of dollars, right? The money that you have, the Department of Health, that you could use to treat these kids. And I would like you to work out that fiscal note, okay? Whether it's in the supplemental, whether it's the money that you have that you can look at some programs, but this should be a priority, okay? And I know I spoke to Deputy Secretary Laura earlier, and there was a way to maybe scale it, to do it in several years. We need to figure it out. It needs to be done. And what I also was thinking, I made a note here, is that we don't have any reporting in the bill. I want some reporting every year to this committee and the committee across the street to see how we're doing. Because we're not gonna drop this, okay? So what I like to do is a crossover is March 17th. I would like you both to get together and try to figure out the fiscal note with June Chung, with the governor's office, and the appropriations committee. Let's figure this out. I would like you to come back and say, here's the money. We're gonna do it. Is it clear?
Yes.
Yes,
Okay.
Madam Chair. And to your comment about reporting, the Department of Human Services has made the commitment to the appropriations committees, and the delegates have heard us say this. We intend to launch public-facing dashboards with our information, including with our youth in hospital overstays. And we intend to do that this year as soon as possible. So we're fine with a report, but it's going to be on a dashboard.
Thank you, I appreciate it. And we're gonna put something in the bill that it has to come in writing to the committees as well. In June, I know you're not signed up, but I need you to please lead this. Let's get this done, okay? And work with our sister committee to see what we can do, all right? We gotta take care of this. This is it, it's enough, okay? Thank you so much.
Thank you.
Thank you both, appreciate you. And before you leave, can you agree? Oh, Delegate Kaiser, sorry.
Madam Chair, I don't want to stop you from leaving. I was trying to get the attention of Madam Chair in 1 minute, so.
Okay.
So I had a question, but you were trying to say goodbye, so I don't want to stop
Oh, no,
you.
go ahead.
My question is for MDH. Last year, when Delegate Rosenberg had his bill, House Bill 1376, you all were unfavorable on this overstay issue. And the meetings that I was involved with, there was a lot of balking at a lot of the solutions. So I'd like to understand what has maybe changed in the past year, or what have you all been working on that you say you've been working on for a few years in regards to this?
Yeah, so I'll have to take your first question back since I was not here last year for those conversations, but happy to do that and circle back with you. In terms of things that we're working on, specific to overstays, I mentioned HB 1121 of 2020 calls for the bed registry and referral system, which is something that Madam Chair has really been spearheading. So we currently have a hospital care coordination dashboard where you can check the availability of beds. It's updated 3 times a day, but we're actually in the process right now of procuring a vendor, a software vendor, to have a real-time bed registry and referral system. So we'll be able to see the availability of beds and other services in real time. And that's why I mentioned in my proposed amendment that we think it's really important that hospitals and all providers, our behavioral health providers, are required to provide information to this bed registry and referral system to ensure that we have accurate and real-time information. So that's one thing we've been really focused on that we're really excited about. Another thing we've done is we've funded the 211 Behavioral Health Care Coordination Program that we refer to as 211 Press 4. And in this program, we connect emergency department staff with community-based behavioral health resources. So there is a resource for emergency department staff to call and get support in connecting patients to services. So that's another thing that we've had underway. We've received about 600 referrals in calendar year 2024 to 211 Press 4 to help get access community-based services. Another thing that was mentioned is Brooklane today, which is the first residential crisis program in Maryland. It serves as a step-down program. So youth who are overstays at inpatient units or emergency departments but have been accepted into a placement, this is really a bridge program for them. So that's another thing that we've done this year. As was mentioned in the budget hearing earlier, we have those 7 beds. We also have another 7 inpatient beds that are going to be coming online soon. These are inpatient youth beds. So that's another thing we've been focused on. Chair Shetty also mentioned the residential substance use disorder treatment program for minors, which has been another priority that has a capacity of 15 beds. So lots of work going on there. And then I would just add that we're doing a lot to try to get more upstream, right? We want to prevent our youth from going to the hospital. So we've talked about today more community-based services, more prevention, more treatment, more crisis services. And so we're working to build a full continuum of crisis services around the state, including promoting a model that's specifically focused on youth and families. 1915I has come up, so there's the pediatric overstay work, and then we're doing a lot to try to build the full continuum to try to prevent youth from going to the hospital in the first place and ensuring they can get the care they need.
Thank you. So before I leave, I know that I'm going to go to a meeting. Chair Chetty just came, and she's going to ask a few questions. And I know that before I leave, I challenged you, I asked you to meet, right? And that I want you to figure out the fiscal note and that we have to do this. And June Chung is here, and I challenge her to go to the governor. We need to find the money and to work with our sister committee appropriations because this needs to be done. I know you have some amendments, right? And I need you to meet, and I need you to tell me that you have worked it out, okay? You can go ahead and ask your questions. I'm gonna go to my meeting. And thank you so much. And thank you for working with us. And I want to thank Deputy Secretary Lohr. I call her all the time. I know she's sick of me. She's gonna probably block me after session is done. But she's been amazing to work with. And I thank the department. You really are working hard, and as well as Webster, okay? And Rachel, thank you so much. Go ahead.
Madam Chair, I think I got a call from you at like 11 at night yesterday.
I know.
So I'm happy to take the call.
I did. Can I just say, I have no shame, none.
All good.
Several of those late calls. I appreciate you taking her call because it's always important. So I apologize for stepping out briefly. I had to meet with other members of your team to talk about another part of our budget. But I wanted to go back to the questions I asked, please, to panel one, which I recognize is way more appropriate for your panel. We talked about in our Behavioral Health Administration budget hearing today a couple of the planned uses of the behavioral health budget for FY26, namely hospital discharge for RRP community expansion, $2 million for that, 1.06 million for 15 beds additional in Montgomery County for step-down substance use disorder treatment. And then I want to dive in a little bit more in detail, please, on the 10.3 million for the 1915I enhancements that are going to go into effect in April. I know that the hospitals have indicated that a big part of the challenge has been, even with the Brook Lane, post Brook Lane, what happens to these children? Are we giving them the wraparound supports? And I'm wondering if some of that 10.3 can please be dedicated towards some of these efforts or used for some of these efforts. And then related to that, on RICA staffing, it remains very puzzling to me that we have the facilities but not the staffing there. And I see that the fiscal note for Chair Pena-Melnick's bill includes money for increased staffing there. But I thought that our FY26 allotment included personnel pins for those facilities and that the challenge has been recruitment and hire. So my question is, which one is accurate? Is there actually money needed to staff up RICA, or is it already included as part of FY26, and is your plan to hire these people to staff these beds, please? Thank you.
So on your last question, since it's fresh in my mind, I will take that question for the record and we will get back to you. In terms of the question about 1915I, I can talk about it at a high level and then happy to get, I'm sorry, sorry. We had started leaving earlier and then came back, sorry. So I can speak to 1915I at a very high level, but that's another area where we'd be happy to circle back. So we are improving the 1915I in order to enhance community-based services for youth. And so the updated 1915I seeks to reduce eligibility barriers, simplify the enrollment process, and improve access to 1915I services. And so our Medicaid state plan amendment was posted for public comment, and that closed just at the end of January. And we anticipate submitting it to CMS, the Centers for Medicare and Medicaid Services, next month. So that's a high level on 1915I, but we're happy to provide additional detailed information about it.
When you follow up, please, the question is, you all have indicated in your budget request that $10.3 million would be utilized for expansion of slots from 200 to 1,800, effective starting in April. So the question specifically is, can some of these services be utilized and the funds for this waiver expansion be used to help address this challenge? So thank you. I look forward to that follow-up. Thank you.
Thank you.
Okay. Delegate McCaskill?
Thank you, Madam Chair. I have a question. Thank you for returning because I was burning to ask that question. And so we've heard the conversation over and over again about our children not receiving the services they need in the hospital stays. But I'm also concerned about those who go to the hotels for the unlicensed settings. And so is there any type of consideration or ban to send these children to these types of settings?
I'll take that, Delegate McCaskill. The short answer is yes. Our policy that we issued on February 7th also affects hotels as well. As you've heard in our budget testimony at the Social Services Administration, we have also focused intently on reducing the number of hotel stays. I believe we're at 24 hotel stays right now, youth in hotels, and that is not acceptable. We agree. About a year ago, I believe we were at 51. So again, just like with hospital overstays, we are doing the elbow grease to make sure that each and every one of these youth gets a phone call, gets every possible effort by both our local office and the Social Services Administration to get that addressed as fast as possible. And that could be as simple as we'll go down and we'll start calling providers who have said no. And we'll ask, why did you say no? And if you've said no previously, will you please reconsider? And if the answer we don't get, many of our relationships are contractual on the DHS side. And we'll simply say, thank you for your service in that case, if you don't want to take one of our kids.
Thank you. One follow-up. And it may not just necessarily be a question, it's my burning concern. I appreciate that answer. I'm just really curious around timelines and more of an effort of just phone calls for these children that's in these hotel stays. And perhaps we need to make some other considerations around regulating in the meantime and tightening the belt around these children for these hotel stays, and even making some kind of considerations around how we can expand those types of foster stays or other regulated settings. Like, what do we need to do to remove the barriers to expand those placements?
And Madam Delegate, I think the two biggest items, the General Assembly were extraordinarily kind and led with leadership last year. And the first was the General Assembly passed a kinship care bill, which completely changed how we addressed foster youth in our state. And that allows us to, Delegate Taveras' earlier point, try to get to youth ahead of time. With the back end, the appropriations committees supported us in implementing rate reform, which took effect on October 1st. And I think, as some of the testimony earlier pointed out, that drastically changed both how we pay for services and allowed for provider accountability by saying, hey, here are the services that each class of providers need to provide. And that has helped us place kids more consistently and faster.
Thank you, Madam Chair.
Delegate Taveras and then Delegate Woods.
Thank you, Madam Chair. To this point, I just want to piggyback real quick. The money that we're spending on the hotel stays is enough to cover places like boys' home that are essentially free of charge. So the thing is, we just got to be comfortable to send them across state lines. And the thing is that not all of our families are perfect. So if we do have a caring family and they're in the state, yes, get them early. But maybe the outlash is because we're not in a healthy family and our children are hurt somehow or traumatized somehow. And so these are also places that we want to make sure that where we send them are places that are going to be, they're not going to end up in a TV movie about how these kids made it out after, you know what I mean? So we just want to make sure that we're sending them to good places. Yes, I do. I think that maybe now I forgot, caramba. No, but I was concerned about the hotel issue, for real. So is it possible, how much are we spending in hotel stays? Like, how much is the cost per year?
So Delegate Taveras, I think the first part of your question of isn't that right is yes, that is right. And we agree with you. We want to minimize the placement of our youth out of state to the maximum extent possible. Because to your point, it is harder to ensure that there's a consistent level of quality for children out of state. But that said, we have 3,688 children in foster care across the state. Of that number, 20 are out of state currently. That is not an ideal number. We would like it to be lower. What we're doing with that perspective, when we are placing out of state, youth out of state, excuse me, we are trying to do everything we can in cooperation, partnership with our Department of Health colleagues to ensure that those out of state providers are, even if there's, we will not place a child in a out of state provider if there is even an allegation of impropriety. That's made it a little bit harder, but we want to make sure that our youth are placed safely. To your point about hotel costs, I think I can say, and your Appropriations Committee colleagues have heard this, say this repeatedly, our data is in a state of refinement. We have worked to improve our data gathering, including our fiscal numbers, over the past 2 years. 2 years ago, we did not have good data on the number of youth in hotels and how they were paid for. Now we are having better information. And so that is an item that we are working to improve.
Okay, now I recall what I wanted to say. I just want to make sure that since we are so strapped, we want to make sure that we're doing the best return on investment, right? And so when we're caring for a lot of these children, particularly the ones that are in substance abuse, that have substance abuse disorders, when we send them back, straight back home from a 7-day, 21-day, to me, which is not enough, detox, they need to go away to a rehab permanently, 6 months to a year. And from there, we could graduate them to these residential programs like the schools. Because if we don't, they're just going to go back to the street within a day. And
that is certainly an issue, but it's not the issue in this bill. So I'm happy for us to have that conversation with the folks from DHHS on internally out of this hearing.
But they just mentioned the 1.6 million, the 2 million for the hospital detox.
Okay, but we're focusing, we're going to focus right now on the kids who are staying in the hospitals beyond when it's medically necessary. And that's the focus of what we're talking about. But,
okay, all right,
I mean,
thank you.
I appreciate your absolute commitment and passion around substance abuse for children. So please, I'm very respectfully saying, let's stay on the bill.
Yeah, I'm just trying to find money.
Okay. I appreciate that. Delegate Woods.
Madam Chair, may I request permission to be Terry Hill for a few?
All right, so you have yours and Terry's, and that's, excuse me.
So,
Thank you, Madam Chair. I want to follow up on Delegate McCaskill's question, and I hate to kind of push this, but can you, so you made the statement about the hotel stays and reaching out to these contracted organizations. First question is, all of the contracted organizations that you refer to are therapeutic foster homes. Is that correct?
Delegate Woods, it includes residential child care providers as well. So it's about, I want to say about 90-ish contracts.
So then my question becomes, you said that you would ask them to reconsider after they've denied. Would that not put us in more of a difficult situation? Because if you say goodbye to them, which my other question that I didn't ask was how, you said it's about 90 providers, but you're talking about childcare and therapeutic foster homes?
Yes.
Would it not put us at more of a disadvantage if we got rid of some of these contractors because they're not taking our youth that have these serious therapeutic needs?
Delegate Woods, I think it goes both ways. We have a contract with the state of Maryland with these providers for services. To date, we have not canceled a contract. What we have done is implemented a modern rate structure, and the rate structure has been based on cost. So it's substantially more for more defined services. And we are asking in return for increased rates, greater accountability both to us and to the providers as well. And so when a provider who is getting an increased rate is saying, yes, we have an open bed, we are going to ask them, if you have an open bed, why won't you take our kid? It might be as simple as they only offer beds for females in a certain age bracket for a certain number of clinical criteria. And Webster, for example, might be the wrong gender or the wrong services in that case.
But that's not normally the case, is that correct?
I think, Delegate, at this point, after a lot of work, it is no longer systemically wide issues. We would argue that it is more specific. So of the 12 youth that are currently in hospital overstay, we have identified placements for 8 of them. Now it's a question of working with those providers to get them into that bed. With the other 4, it's a matter of figuring out every 48 hours, whatever period of time, writing down the latest progress and then working to get that youth placed in the appropriate environment, which is, I think, as we all agree, is the least restrictive, clinically most appropriate place.
And I promise I'm not going to be much longer. How many of these youth have, and I know Maryland may not call it DYRS, maybe are on ankle monitors?
Delegate, I don't know the answer to that.
And then my last question, I know we keep talking about the least restrictive environment, and I kind of have the concern that sometimes when we send the youth out of state, and you've heard me mention about Devereaux, Georgia, I don't even know if they're still having RTC, but there are programs like that that have services that are very appealing to our youth, that provide the type of intensive support in, while it's not a restrictive environment, but they have so many opportunities that we've seen youth thrive well. I just really think that we need to re-examine some of the facilities like that offer so many arrays of services. I know Devereaux, Georgia, when I had kids there, you know, they had the GED program, they had the barber program, they had mechanic programs, they had working, you know, programs where the kids had an opportunity to work. And so sometimes that to get them out of the environment may be more beneficial. And so I'm really hoping that we would really be more open about looking at the out-of-state RTC programs.
And Delegate Woods, as I said in my original testimony, we agree. We are intending to get that solicitation out this spring, and we're inviting any interested provider to come up and say, hey, this is what we're interested in providing, and we hope to come to an agreement.
Thank you. I appreciate that. And I missed that. I might have stepped out when you said that, but thank you so much. Thank you, Madam Chair. Thank you, Madam Hill, Delegate Hill.
Delegate Hill, right. I think that's all the questions for this panel, I think, right? Thank you very much for your time and testimony, and for your patience with all these questions. We have 2 more favorable witnesses in person, if they're still here. Ann Geddes and Margaret Colopi. Okay. Okay. Thank you.
Yeah. Thank you, Madam Chair and committee members. I'll be brief. I'm Ann Geddes. I'm with the Mental Health Association of Maryland, here in support of House Bill 962. The chair said everything I was going to say, so there's no need for me to repeat it. Mental Health Association strongly agrees with everything she said and with the benefits of all the components of this bill. Based on the conversation that's been had, I just want to stress that these youth children who are stuck in emergency departments and hospital psychiatric units, for the most part, are kids with the most serious and complex behavioral health needs. And the component of the bill that directs the Department of Health to do a rate study and look at a prospective payment model and try to right size RTC rates is really important, because these kids with these really acute needs, RTCs need sufficient reimbursement to adequately staff their programs and provide treatment, appropriate treatment for children with really high acuity needs. So I just wanted to stress how important that part of the bill was to us. That's all.
Thank you very much. Are there questions for this witness? And let me ask again, is Margaret Colopy here? Okay. Virtually, we have William Geisch, I think.
That's all.
Okay. Questions for this witness? And let me ask again, is Margaret Colopy here? Mr. Geisch, you need to turn off the YouTube channel. There we go.
Hi, good evening, everyone. I am Will Gouch, an assistant public defender. Our agency has submitted written information regarding this bill, and we thank the MHA, Madam Chair, and other delegates for attempting to address this important issue. Our agency is also in support of amendments that were proposed by Mitch Mervis on behalf of himself, Disability Rights Maryland, and the Office of the Public Defender. Today, I am here to highlight our agency's major concerns with the bill as it is currently written. Our first concern is the promotion of residential treatment centers, or RTC placements. Many of the children impacted by this bill need more robust community and home services, not RTCs. RTCs are not a catch-all and carry with them their own risks. In 2024, the U.S. Senate Finance Committee released a 130-page report of their 2-year investigation into major RTC providers across the country. The report found that children placed in RTCs risk being overprescribed, overdiagnosed, many instances of physical and sexual abuse, and the overuse of seclusion and chemical restraints, which are injections intended to keep children calm. This was found to be a direct causal result of the RTC operating model, which incentivizes the providers to optimize revenue. These issues dovetail into our second concern, the portion of the bill dealing with out-of-state placements. Out-of-state doesn't just mean another part of the DMV. It could be Texas or Alabama or somewhere farther away. This bill seems to prioritize placing children quickly instead of safely, and in doing so may take the child out of the environment that they know. As a public defender, I've seen the Department of Social Services request and have granted the ability to tranquilize a teenager to send them to an out-of-state placement. That placement went very poorly and added additional stress and trauma to a child who is relying on the state to manage their care. We agree that this is a major problem, but the solution to that problem should not cause additional problems for the children. Thank you all for your time.
And thank you, sir, for staying and being so patient.
It was my pleasure.
Questions for this witness? Looks like you got off easy. No questions.
Thank you, everyone.
Thank you. I'm sorry. I spoke too soon. Delegate Taveras.
I know. I love your testimony. Can you please send a copy of that report? Thank you.
Absolutely.
Okay. Thank you. Delegate Bagno.
Thank you, Madam Chair, and I was trying to resist, I really was. But I just want to make sure that you're coming to the table, because I am concerned when I hear, that we can't look at out-of-state, that we're trying to make sure that we're doing quick placement rather than correct placement, because this committee has been very committed to making sure that we were scaling up the services that we needed. In fact, the 1915 I waiver was in fact my bill, but it takes time, as we know. It's taken a number of years just to get the regulations, just to scale it up. We know that we have a workforce crisis. So I want to make sure that when you're coming to the table, you're coming with an open mind, that we can do more than one thing simultaneously, and that this is not an either and. Isn't that so?
I think I absolutely agree with you and what you were saying. Our position isn't that an RTC is never the appropriate place for a child, or that an out-of-state placement may not be the appropriate place. It's simply making sure that children who need different levels of care are not being sort of washed away in that movement. I will certainly bring the question back to our team, and they, I believe, would be more than happy to talk with you more.
Thank you very much. Thank you, Madam Chair.
Thank you, Delegate. Okay, seeing no further questions, that completes the hearing on House Bill 962. Thank you all for your time, for your patience, for staying with us today. And that concludes the work before the committee today. I'm going to ask the committee to sit for a minute while we go down, because there are a couple of announcements.